Yes, yes. So I welcome you all to today's meeting, which is on the case discussion and journal club. And I think this is the fourth meeting of the Raise and Rise. And I think this meeting has really made us wise, and it gives us a platform to exchange the knowledge, and it has become a platform for social interaction also. So I'll hand it over to Dr. Rishi to conduct the meeting further. And excuse me for my absence in between because I've got an essential commitment with the USI Council at present.
No issue, sir. We
Dr.
will
Rishi,
come here, and whenever you can join us, please do so. There is a slight change in the program. The program, as you all know, has been convened by Dr. Sameer Trivedi, who is also a council member of the Northern USI. He has designed the program, and he would conduct the rest of the session. We have changed the last session as the first session because of some personal issues, but rest of the program will go on from there as scheduled. Dr. Sameer, please, you can take over.
Yeah, thank you, Dr. Rishi. Good morning, everyone. And as we know, this is the second edition of Residents Assembly. We had the first edition in January, which was quite well appreciated, and residents also were very appreciative. And so it's an excellent initiative from North Zone, and particularly Dr. Rishi, who is our secretary. And in continuation of the same trend that we had last time, we have designed a program which caters to most of the practical issues. And the benefit for residents is that they get to hear from experts and examiners who would be examining them at various places in different forms and formats. So they get to have an wider exposure of experts, and topics are fairly straightforward, routine clinical issues that they encounter in their day-to-day practice. So with that, we'll start with the program, and the first session, as Dr. Rishi has already pointed out, is the drug spotlight session. And we have a very eminent speaker, Professor Apul Goyal from KGMU Lucknow, who needs no introduction, excellent academician, currently the editor of IJU. And he is going to speak about a drug which all of us are using routinely, but there are many finer details and nuances which need to be elucidated. And as clinicians, we sometimes fail to focus on the pharmacokinetics and pharmacodynamics of a particular drug, and we are merely swayed by whatever has been told to us by the pharma industry. And so it's time to look at common drugs in urology one by one. So this time we are focusing on PD5 inhibitors. And the objective of the talk is to focus on practical issues, how to use this drug, what precautions to take. And then we will have a discussion. And for discussion, as usual, we involve a senior resident. And this time we have Dr. Yunus from SKIMS, Shere Kashmir Institute, Srinagar. And then a panel of experts who are all leading andrologists in their own right. Dr. Ajit Saxena sir, Dr. Vineet Malhotra sir, Professor Arif Hamid from Srinagar, and Dr. Rahul Gupta from Jammu, who is our own council member. So with that introduction, I invite Professor Apul Goyal sir to start his talk and share this.
Thank you, Dr. Sameer and Dr. Rishi, for inviting me to give this presentation. So how do I start? So post. No idea. There's a window that has popped up which says that who can share, host only, all participants, but how do I share?
There is a share button at the bottom, sir.
No, that I know. So on pressing it, there's a window
Apul, you might have to be made a co-host.
Okay. So please make me the co-host.
You need to be made the co-host to be able to share.
Okay.
Who will do that? Navneet ji will do
that. Navneet will have to do that.
You are already a co-host, sir, on the list of participants.
So there's a window that has come up.
He is the co-host.
Advanced, who can share? See, there's a window which says who can share. There are two options: host only, all participants. So it's already marked at all participants. And who can start sharing when someone else is sharing. So again, it's all participants. But this window is not going away. So
reshare. Undo and reshare, sir, maybe.
Sorry?
You can stop it and
That
reshare
close
it.
that
So
window
maybe-
and reshare.
Yeah.
Okay, now it was
Start again. You should be able to do it.
Yes.
Yes.
So is it visible?
Yes, sir. Go ahead.
Okay. So thank you once again, North Zone, and especially Dr. Samir Trivedi and Dr. Rishi for this opportunity. And I apologize for disrupting the program. And my presentation was last, but shifted as the first presentation. Thank you for that also. So I'll be talking about phosphodiesterase 5 inhibitors as a group. And as I was just sharing with Dr. Ajit, these drugs are like aspirin today, and these drugs find usage not only in urology but in other fields like cardiology and pulmonary medicine as well. So this presentation will give you an overview about the entire group of these drugs, and then I'll be discussing about the role of this class of drugs for the three common indications that we use for, that is erectile dysfunction, BPH, and a little bit about OAB. So this presentation is actually an overview. So if we talk about PDE5 inhibitors as a group, so it constitutes a superfamily of hydrolytic enzymes that degrade the second messengers, which is CAMP and CGMP. So we are all aware that CAMP and CGMP are the molecules that are released within the cell, which has different actions within the cell. So and phosphodiesterase are these enzymes, and this PDE inhibitor naturally blocks these enzymes. So what happens? It enhances the NO-dependent smooth muscle relaxation by inhibiting these phosphodiesterase enzymes. So let me highlight that again, this is an observant attitude. See, these drugs were initially used to treat hypertension and angina. But because of this observant attitude, it was noticed that when giving these drugs for these patients, there was erection in the penis. So the discovery was actually accidental. So as I said, there are many drugs in this class, and some of them are FDA approved, like sildenafil, vardenafil, tadalafil, and evanafil. And of these three are available in India as well. And we also have non-FDA but commercially available drugs. So these are not available in India and will not go into those details. Coming to the indications, we are all aware that erectile dysfunction is the primary indication for this class of drugs. But to get the best results, you need to combine these molecules with etiology-specific therapy as well. For example, if the patient is having hormonal insufficiency, you need to supplement the hormones as well. So you need to combine these drugs with etiology-specific therapy. As I mentioned, these class of drugs are also useful in idiopathic pulmonary hypertension. Again, as a single drug, it is not indicated for premature ejaculation. But if premature ejaculation is associated with ED, then these class of drugs are used. And they are used in high altitude illness. They are also used as a penile rehabilitation after radical prostatectomy. And of course, they are anti-anginal, but currently they are not in use for this purpose. And as I mentioned initially also, they are used in lower urinary tract symptoms. There are other emerging indications like heart failure, stroke, peripheral neuropathy, used for improving fertility, peripheral arterial disease, and diabetic nephropathy. So there's a wide range of indications that are emerging for this class of drugs. And this is an article in the previous month, published in the previous month, April of BJUI, which says that does Viagra really prevent Alzheimer's disease? Now, again, because this molecule affects different organs, so people are looking at concomitant advantages. So if you are using tadalafil for erectile dysfunction, so there might be associated improvement in cardiovascular events as well. So there's lots of literature emerging about the use of this class of drugs for different indications. I have intentionally kept this slide in the beginning because we all use these drugs, but often we fail to realize the side effects, the adverse events of a particular drug. And as for alpha blockers also, the side effects like postural hypotension are because no drug is actually really selective. So similarly, PDE5 inhibitors should actually inhibit only this class of enzyme, PDE5, but actually the side effects are because there are so many phosphodiesterase enzymes in the body, and these drugs are not genuinely selective for PDE5 only. So the common adverse effects are mild headache, flushing, which is more common with sildenafil. There's a blue vision, and this is because sildenafil especially inhibits another enzyme which is present in the rods and cones of the retina, which is PDE6 enzyme. So this side effect, but is because of action on this enzyme. And fortunately, there is no structural or functional changes in the retina because of this side effect. Another side effect, common side effect, which sometimes goes unnoticed, is back pain, which can be really severe, and this is because because of its action of these drugs on PDE11 enzyme as well. And then there's a risk of hypotension and dizziness, and this we need to remember because we are now combining left and right these class of drugs with alpha blockers. So if you are using this class of drugs along with alpha blockers, you need to be aware of hypotension. And then another side effect is rhinitis. There are other rarely encountered side effects, but this has not led to the ban of these drugs. And this is non-arteritic anterior ischemic optic neuropathy because these side effects are very rare. And this is painless decrease in vision in 1 hour, which is usually irreversible. So it's a serious side effect. And there are risk factors for this side effect, which include hypertension, diabetes, hyperlipidemia, and cardiovascular disease. And another serious side effect is hearing loss, which is because of sensory neural hearing loss. And if misused, it can lead to priapism as well, especially if combined with alcohol and recreational drugs. So again, we need to remember the contraindications, absolute contraindications being patients who are using nitrates or nitroglycerin, because it may lead to excessive preload reduction. Then patients who have arrhythmia, especially vardenafil, and there are relative contraindications like history of MI, stroke, or life-threatening arrhythmia in the last 6 months, resting hypotension or hypertension, history of heart failure or unstable angina. So these are absolute and relative contraindications. Now coming to the urological indications, these three conditions, it is commonly used: erectile dysfunction, BPH, and OAB, and these conditions are actually linked with each other. So coming to the history, so sildenafil was the first PDE5 inhibitor that was introduced in 1998. The second one to be introduced in the market was vardenafil. Then came tadalafil again in 2003, a few months later after vardenafil. And it was nicknamed the weekend pill because of its 36 hours effectiveness and it offered spontaneity. The fourth drug, which was FDA approved, was in April 2012. And the benefit was that quicker effect. Within 15 minutes of consumption, it starts having effect. So this is a slide which tells about the pharmacokinetic details of this molecule, the various drugs that are FDA approved. Now you can see only these two things, the Tmax. So if you see the Tmax of evenafil is the shortest, 0.5 to 0.75 hours. So within an hour, it starts having, within half an hour, you can say, it starts having effect. And T half, which is longest for tadalafil, 17.5 hours. So it has the longest effect. So again, the slide shows the usual dosage, the administration time, and the time frame of efficacy. So as you can see, tadalafil has the longest duration of action, and evenafil starts action with very early, within 15 to 30 minutes. So except for tadalafil, the rate and extent of absorption of all PDE5 inhibitors are diminished when they are ingested with high fatty meals. So this needs to be remembered. Often what happens, we prescribe these drugs and the patient is not happy, although the patient is consuming these drugs. So you need to check whether the patient is consuming these drugs with high fat meals. So often what happens, the patient takes it after dinner. So you need to see this aspect. So PDE5 inhibitors are eliminated predominantly as metabolites in the feces and to a lesser extent in the urine. All these have a shorter half-life of 4 to 5 hours, but as I said, tadalafil has the longest half-life of 17.5 hours, which allows its use as a once daily agent and has a long duration of effect. As I said, it's a weekend pill. Now, coming to the efficacy of these molecules which are available in India. So, this meta-analysis published in 2009 evaluated 16 trials, and as compared to placebo, which was effective in 35.5% of the patients, it was effective in 69%. So, and there was a 34.4% improvement from baseline in successful intercourse attempts. If you talk about tadalafil, almost similar success rate, and again, a similar improvement from baseline in successful intercourse attempts. One of the most cited reasons for poor response to treatment of ED is lack of spontaneity with on-demand dosing. So this is the drawback with most drugs, which is not there with tadalafil. And so it's more natural because of its long action. So it has been said that probably it's a cure for ED. There's another concept called chronic low-dose PDE5 inhibitor therapy, and can be used for difficult to treat populations such as patients who are diabetic, who are post-prostatectomy and post-radiotherapy patients. It may be an alternative for men who have not responded to other PDE5 inhibitors or traditional on-demand dosing. So this sort of dosing can be given to these patients. Now, as is the debate with alpha blockers, there's a debate because there are so many 4 molecules that are available, which are FDA approved, which is superior to, which is the best. So head-to-head comparison trials are not there. And there's no evidence, whatever little evidence we have, there's no conclusive evidence about the superiority of one agent to the other. But most men have said that tadalafil is probably the preferred agent because of its extended duration of action. Now, coming to the second indication, which is in patients suffering from LUTs. And we are all aware that when we are evaluating these patients, whenever we are taking IPSS, it is recommended by all the EAU and AUA and EAU that you need to measure the IIEF scoring as well. So the mechanism of action on LUTs, the exact mechanism is probably not known, but it probably increases the blood perfusion and reduces chronic inflammation apart from the usual action on muscle relaxation. So of all the 4 agents, tadalafil is probably the most studied and is the one which is FDA approved for this indication. Is used and various trials have shown that it is effective. So it shows that it reduces the IPSS, the storage and the voiding LUTs, and it improves the quality of life. However, the Qmax doesn't change much after these drugs. So, and the people who are most benefited with this class of drugs are younger men with low BMI and more severe LUTs are probably the people who are benefited the most. If we talk about whether there's an impact of prostate volume on the efficacy of these drugs, so they are effective regardless of the baseline severity, the age of the patient, the total testosterone level, or even the prostate volume. So these drugs can be given for any size of the prostate. There's another interesting thought that comes to our mind, that is IPSS improvement attributed to indirect treatment effects via IIEF erectile function improvement. So whether the effect is because of its direct impact on IPSS or BPH, or is it an indirect improvement? So people have looked into this and they have found that actually the improvement is more directly related to BPH aspect, 92.5%, and there's also a 7.5% indirect treatment effect through improvement in IIEF. So it's both ways, it acts both ways, but primarily as a primary agent rather than because of its effect on erectile function. So we have this EAU evidence which says that phosphodiesterase 5 inhibitors significantly improve IPSS and IIEF score, but not Qmax. Coming to the side effects, if we combine alpha blockers with PDE5 inhibitors, so essentially the side effect profile remains the same. you give alpha blockers alone or you add PDE5 inhibitors, the side effects doesn't increase much. So the combination is safe. So again, the evidence says combination of PDE5 inhibitors and alpha blockers improve IPSS, but magnitude of effect on clinical significance is low. And but again, another whether it is effective in women as well. So there are trials exclusively done on women. So again, it shows that it is effective. Coming to OAB, so
Apul sir,
yes.
time sir, we are overshooting the time a little bit, sir.
Okay, so we have proof of principle studies available, and in the detrusor muscle, various enzymes PDE1 to 5 have been shown, and the predominant enzyme is PDE1 in the detrusor muscle. So there's a rationale to give PDE5 inhibitors, and there's a combination of PDE4 inhibitor and PDE5 inhibitor that can be used. And again, because of it, the effect is probably that it improves the blood perfusion and probably more relevant in women who have metabolic syndrome type of phenotype of OAB. Thank you so much. Thank you.
Thank you, sir. The chairpersons can take over, and I think our senior resident for the session, Dr. Yunus Mustaq, he can have a few queries or comments before the chairpersons take.
Yes, so thank you so much. Thank you so much for giving me an opportunity. As sir said, that for optimization, that we have to counsel these patients to avoid fatty food except tadalafil. I've gone through one study that showed that around 55% patients were previously not successful with the sildenafil became successful after re-education and counseling. So is there any particular role in educating them and counseling them before prescribing this drug? Like arousal is must. And if there is a decrease in testosterone, for example, patient comes with decreased libido, is actually have a decreased testosterone level. And if we supplement those patients with testosterone and counsel them and educate them before giving this drug, is there any role?
See, education plays a very important role in the treatment of erectile dysfunction. So there's no doubt about it. So you need to counsel the patients. Many have psychological issues only. So we need to identify, as I said in my slide, you need to combine these drugs along with treatment of the primary reason for erectile dysfunction. For example, as you mentioned, there's hormonal insufficiency. You need to supplement testosterone to get optimal results. So but there's no doubt about appropriate patient counseling and education.
Okay, sir. Thank you. One more query I have regarding nitrates, as nitrates are absolute contraindication for these drugs. There was Princeton Consensus Conference in T4 where the panel agreed upon that around 35 to 40% of patients actually don't need these drugs, nitrates. Do we have to re-stratify, because if we are supposed to give them sildenafil, that's an absolute contraindication, nitrates. Do we have to refer these patients to respective cardiologists before, or we have to re-stratify by ourselves? Because the consensus agreed that 35 to 40% of patients actually don't need nitrates.
So actually, we are probably not the right people to take these decisions actually. So my thing is that I typically refer these patients who are on nitrates. I don't prescribe, first of all. And in case they are very willing for trying these drugs, so in that scenario, you need to refer the patient to a cardiologist. So I don't think we are the right people to take these decisions.
Two more little queries. One is related to the tadalafil. As you said that we have one is on demand, and second we can give tadalafil 5 milligram daily. There has been studies that show superiority of that. But is there any a concern of tolerance dependence or tachyphylaxis? Because patients usually they worry about if we take these drugs for a long period of time, probably it's not going to work next day or next month. Is there any role? Do we have to concern about these tachyphylaxis and all?
Yes, this is, I think, a very good question, which was not there in my slides. So there are studies up to 2 years. and there is no loss of action. So they remain equally effective. They are almost like alpha blockers, which can be taken for a very, very long period of time. But the literature that I came across was up to 2 years. Maybe now there's more literature on it. I'm not aware of. So, but the belief is that the effect remains.
True, because even most of doctors, they even say sometimes that if we give it for a long period of time, it's not going to be effective. But studies show other way around.
Yes.
One last question is, sir, about the Princeton Consensus Conference. That session was about the regularities and public health perspectives. That showed around 4,000 products were dietary. They were sold as dietary supplements, as immune boosters in the market. In 1994, there were 4,000 products. Right now, there are 75,000 products in the market. And studies have shown even some may contain the therapeutic level of pharmaceutical agents like sildenafil when they were checked. So do we have to inquiry about these drugs before prescribing? Because if we are prescribing sildenafil, there might be the double dosage of the particular drug if they are taking. And most probably, most of the patients, they try here and there, and finally they reach the concerned doctor they should have visited at first place.
So I think you have already answered. So you need to check if the patient is taking supplements and it's already mentioned that it contains sildenafil, for example. So naturally you have to be aware and the dosage doesn't increase. So, but I'm not sure whether sildenafil is there in drugs which improves the immunity.
No,
Maybe, but
so actually there has been
maybe dose of up to 200 milligrams a day, I think is safe enough. So maybe the chairperson can give a comment from that. Dr. Vineet, Dr.
Yeah,
Ajit.
let us hear from the experts, the chairpersons.
Thank you so much, Ajit. Thank you, Dr. Apul, for an excellent session, and thank you, Dr. Yunus, for those questions. Dr. Ajit Saxena, sir, your comments first.
Thank you very much. I think there are two practical points that we need to consider. One is that if you give a patient a sildenafil, education is very important. The fact that he has to have foreplay. Without foreplay, this drug is not going to work, and
Exactly.
and you may spend the whole night just lying down. The other point is that as age advances, there's a decrease in the blood flow to the penis, and therefore these drugs, which are classically said half an hour before sex or 2 hours before sex, you will have to extend the time. Say, so 2 hours, if the patient takes it 4 hours before, he's going to have a much better erection than 2 hours. That's what I'd like to say. We need on.
Thank you, sir. Very quickly, I'll just sum up, I think, what's been asked is, so you need to understand the pharmacokinetics. The nitric oxide release is going to happen through eNOS and nNOS, which means that if you do not have visual or tactile stimulation, you're not going to release eNOS and nNOS, you're not going to generate that pathway, and so there will not be cyclic GMP persistence. That's the mechanism behind stimulation for PD5 inhibitors. You have to do that. It's not using the alternate pathway. The second thing that you asked about was usage of additional drugs. Now, remember, they use alternate pathways. So something like L-arginine is a weak nitric oxide producer. It works through the mechanism of antagonizing the free radical injury that happens through BH4, the tetrahydrobiopterin pathway. So it's going to block it there. This is a completely independent pathway. It's a very weak nitric oxide donor. So if you're going to use that, make sure that you understand why you're using it. One more thing that was asked was about the possibility of tachyphylaxis or no tachyphylaxis. There's enough evidence to show that there is no tachyphylaxis that happens with long-term use of tadalafil. When you give daily dose 5 milligrams of tadalafil, it reaches a trough level of approximately 8 milligrams dosage over a period of a week and then stabilizes at that. So what you're eventually giving is somewhere between 7 to 8 milligrams of tadalafil on a daily dose because of the long half-life of tadalafil. And that's considered to be safe to be used. We've seen men that use 200, 300, 400 milligrams of sildenafil or very high doses of tadalafil also. It's not recommended for use, so we will not really suggest that to be used. Finally, for your nitrates question, it's always best to have that changed by the cardiologist. They have alternate medications very easily available, which they can change to. Otherwise, very clearly, 48 hours is the time duration that you will ask a patient not to use a sorbitrate or a nitrate after having used a PD5 inhibitor. And if he has used it before, then desist for 48 hours from using another PD5 inhibitor.
Thank you. Any final comments, Dr. Rahul, Dr. Arif?
Yes, sir.
Yes, Dr. Arif, please.
Yes, sir. Yeah,
I
I
had
think
one
there's
query to Vinith. Can I ask it?
Ma'am, can you please put in the chat box because there are a lot of queries
Yes,
there.
sure.
So we are slightly over time. We request Dr. Vineet and other chairpersons to please have a look at the chat box and reply to the queries directly on the chat box. Yes, Dr. Arif.
Yeah. I think the most of the queries they have been covered reasonably well. But then we have to see that we have to individualize the approach to a particular patient. I mean, we have to see what are the expectation, what is the basic problem with the patient, and give him a realistic, the viewpoint, what he has to do and how the drug will help. Because that's very important. It cannot be a generalized one-stop solution for everything. So a little bit of counseling with the patient and seeing what is his exact issue, vasculogenic, neurogenic, psychogenic, and then give a realistic viewpoint that how this drug is going to help. How important, as Dr. Saxena said, that the foreplay and all those are important. Then only this pathway will be activated, and then he will get an optimal effect of this drug. So that's very important.
Dr. Rahul. You're muted.
I'll just go to chat box. Thank you very much, Simran, for having me, and the NZUSI for having me. It was a great talk by Dr. Apul. I think the points we are already late, so I'll put that in the chat box. I'll just close it. I'll make it not uncomfortable for the other ones to come. I'll not take the time.
Thank you so much. Thank you all the chairpersons and Dr. Apul sir and you, Dr. Yunus. We always are left with wanting more. There are a lot of questions to be answered, a lot of discussion still take place. I am so sorry we are running slightly late, so I'll have to end this session here. Thank you once again. And please stay on, and I request the chairpersons to answer the queries in the chat box. There are quite a number of queries there. And we'll move on to the next session, which was actually supposed to be the first one, and which is the case presentation session. And I invite the examiners for this, Dr. Diwakar Dalela sir, Dr. Sujata ma'am, Professor Nachiket, and Dr. Hemant Goyal, all very renowned examiners and quite experienced ones. And the case to be presented by senior resident from SMS Jaipur, Dr. Prashasya, and the examinee is from AIMS New Delhi, Dr. Archit. So it would be like a usual case presentation, the way it happens in exams. And I request the examiners to please take over the session and start. Dr. Prashesh, you can share your screen.
Thank you, sir.
The students may please open their video also so that we are able to recognize Dr. Archit.
Yeah, please switch on your camera so it will be better for us.
Yeah, thank you.
Permission to start, sir.
Yes, Prashesh, we can hear you. Please go ahead.
So my patient is a 46-year-old female who presented to our outdoor department with the continuous dribbling of urine per vaginum since 7 months. And patient was apparently well 7 months ago when she underwent a abdominal hysterectomy for dysfunctional uterine bleeding at a private hospital in Rajasthan. Patient developed this dribbling on the post-op day 5. She was catheterized for a few days after surgery. But since her symptoms did not improve, the catheter was removed. At present, she has no normal voiding and has to change her approximately to 5 to 6 diapers per day. In the history, the patient says that the surgery was uneventful. There is no history of any blood transfusion during the surgery or post-operatively. And biopsy was suggestive of chronic inflammatory changes. At present, the patient has no history of any fever or pain abdomen. So in the past and personal history, she does not have any comorbidities.
Prashasya, you should just wait after giving your introduction. Could you go back to the original slide? to the first slide, I think that if you should go back. I mean, can we have the full slide? Because if the person who's taking the exam, if he wants to ask you some further information, then you have to, Archit, do you want to, I mean, are you happy with the presently what he has told? Do you want to ask him anything else regarding the
Yes, so
chief
just a
doctor?
couple of questions. One is, did the patient have any voiding complaints prior to the surgery?
None. No complaints prior to surgery. No.
Any comorbidities?
None. She has no comorbidities.
No comorbidity.
Can I ask you
Okay.
that how do voiding symptoms prior to surgery affect the continuous dribbling of urine which is detected now?
Ma'am, I just wanted to establish that there was no component of neurogenic bladder or anything which would complicate our the the recovery from surgery or corrective treatment that we take up later.
May see the etiology here is iatrogenic, right? It is not
Yes,
related
ma'am.
to the function of the bladder. Usually the cause is an iatrogenic cause which has caused it. So it is unlikely that is gynecologists take a detailed history so as to rule out a neurogenic bladder prior to any hysterectomy, and B is it doesn't have much relevance here. What would be relevant? That she is leaking for 7 months. Is history whether any surgery was attempted in the past, whether any endoscopic procedure was done for her, whether the leak has been decreasing over 7 months, whether she is still on a PU catheter or she is allowed to leak in her pads. And
Right,
usually
ma'am.
it is described as a leakage, not as a dribbling, because dribbling indicates a stream. And leakage
Right,
is
ma'am.
continuous.
Right, ma'am.
I think that inside your opening, time, if you start bringing up things like neurogenic bladder, I mean, most likely there is going to be a genitourinary fistula inside this patient. So if you start, taking, the discussion towards, it becomes a little sticky if you start saying neurogenic bladder and all. I mean, why should she
Yes,
have
sir.
at all a neurogenic bladder? I mean, you do not know the clinical history right now. The diagnosis of neurogenic bladder, it has to be made based upon clinical history, based upon urodynamic findings, based upon video urodynamic findings. So, just jumping the gun and saying that there might be some element of neurogenic bladder, I mean, maybe it's a little premature and maybe it's slightly wrong at this stage, Mother. There are so many relevant things that you can ask
Yeah.
right now for this patient.
Yeah, because you should take your history towards your management, right? That is more important.
Right, ma'am. Yes, ma'am.
So anything else,
So
Archit,
what-
or do you want to continue? Sorry, ma'am, please. Yeah.
Yeah, so during the surgery, you think what in the history would tell you that some catastrophe has happened?
Ma'am, the duration of the surgery, whether there were any intraoperative
Yeah,
blood
you're
transfusions,
right.
and
Yeah. What
any
else?
post-operative ICU stay
Any intraoperative
duration.
consultations with a urologist? Any known trauma to the bladder? Because sometimes they do repair the bladder injuries on their own, na? Gynecologists, they are known
Yes.
to do it.
Right.
Yeah.
Right.
Okay. Okay, proceed.
Yeah. In the past history, there is no other surgical history. She has 2 children, and her bowel habits are normal. There is no addictions, and there is no significant family history.
Family history won't be there, na?
Yes, sir. But
So
just to
even while you presenting, you don't write unnecessary things. No, family history has no relevance. Okay. On examination, what do you want? Don't listen to his findings. What all things do you want?
Ma'am, whether the patient is on a Foley's or currently not on a Foley's, if there's any palpable bladder, where the scar of the previous surgery is, whether it's a final steel or a
I
midline.
think palpable bladder is objectionable because if you are saying it's a continuous leakage of urine, why will the bladder be palpable?
Why
Ma'am,
at all would the presence of a Foley's right now, I mean, be of any, I mean, significance to you? I mean, how is it important presently when you're, taking when the history is being given to you? And how would that, I mean, help you inside anything at all? I mean, the presence of a Foley's. She's continuously leaking
sir,
urine you have already been told that she's been leaking continuously urine for the last 7 months. And Foley's hai ya nahi hai? I mean, why at all is that important to you? Does it take you anywhere? I mean, further to your diagnosis and all?
sir, actually, I was thinking if there is leakage with a Foley's in situ, we would probably start also going toward ruling out a ureterovaginal fistula. So that's why.
Okay, so you think that for a ureterovaginal fistula, I mean, for a vesicovaginal fistula, a person should be on Foley's to decrease the leak, and for a ureterovaginal fistula, it's not necessarily because there's intermittent leakage of urine. Is that so?
No, I think there is no need to make these presumptions because neither of your statements hold true. No? For a ureterovaginal fistula, the patient may leak even with the Foley's, and for vesicovaginal fistula, she may still leak with the Foley's. So I think you should stick to the normal path. Don't try to make your life difficult. So what more do you want to see on a vaginal examination? That is more important. Tell what you want to see about the fistula or whatever it is.
Ma'am, on inspection, whether there's any skin excoriation on a first speculum examination, whether there is there's pooling of urine, whether on a per vaginal examination, whether there's any induration, how roomy the vagina is, if there's any associated perhaps organ prolapse, cystocele, and if the vagina itself is if the fistula itself is palpable per vaginally, what is the distance from the introitus? Any fibrosis?
Yeah, so distance from the introitus, distance from the vaginal wall, is the cervix palpable? How are the margins of the fistula? Whether there is any induration, inflammation, all these things should be noted. And additionally, whether the fistula is stuck anywhere, whether it is stuck to the pubic bone, because some of the fistulas are circumferential, and in them you will not be able to separate the fistula from the pubic bone, which is felt anteriorly.
And we have Dr. Ishori also as the resident here, just to let you know. Yeah. Dr. Ishori and Dr. Archit both are there as examinees.
Hello, Rishi. Okay.
Yes, sir.
Am I visible? Audible?
Yes, sir. Yes, sir. You are audible, sir. Please carry on, sir.
Yes, sir. Please go. Yes, sir. You want to ask some?
Yeah. I was asking during vaginal examination, it is also crucial to assess the vaginal roominess, the caliber of introitus, the stretchability of introitus, the capacity, the capaciousness of vagina important. So that note must be taken during examination, apart from what all the candidate has already said. Yeah. So, okay,
I
go
think
ahead.
that Archit, you should start
Yes,
taking
sir.
a more detailed history. This is because, I mean, if you're presenting this inside the exam, then how the leakage started is also very important. Whether the leakage started early inside the intraoperative, immediately after day 1 post-operative period, showing that there was a gross fistula present, or maybe there was a delayed sometimes 7 to 8 days or 10 days have passed, there is ischemia and then a fistula forms. So it's important for you to take, you should have asked this also inside the history. I think that it's important to know when what the duration of the leakage starting is important. And at the same time, as the female was operated and she had a dysfunctional uterine bleed, then you should have asked about the histology. I mean, when the hysterectomy was done, was it as a difficult hysterectomy? Was it a simple hysterectomy? What was the final histology? Are we dealing with a malignancy which presented as a DUB? So I think that, was it a very large fibroid? Was a fibroid which caused injury to the maybe parametrium causing? I mean, these are things that you have to answer and you have to ask inside the exam. Because if you don't ask inside the exam, then maybe, there are so many things you can just get to know from history. And it's relevant what type of, hysterectomy was done. Was it a planned hysterectomy? Was the emergency hysterectomy was done? So, your history is still, if I can use it, it's still begging from a lot of areas. So this is one feedback that I want to give, that maybe you should be more inquisitive about the history, You learn so many things about just knowing all these things.
Okay, next
Yeah,
slide.
true. Yeah. So can you tell us what exactly is seen in this patient?
On the abdominal examination, there is a horizontal scar in the hypogastrium about 6 to 7 centimeter long, corresponding to the hysterectomy incision. And on the examination of the vagina, it is roomy. The two fingers are permissible easily, and a defect is palpable at the apex of the wall. And the mucosa appears healthy. There is no induration, and the labial folds are good, well developed, and digital rectal examination is normal.
So have you done a per vaginal examination or you have done a per speculum examination?
So we have done a speculum examination as well, but
You should
this is
mention that separately, because you have
yes.
said in per vaginal examination you have commented on the labial fold, well developed, good fat pad. So that is generally not the case. You have to do in a per vaginal examination. You can see the first two lines are okay. You should specify. It was done in a proper position. Upper speculum. It was just an inspection or examination. That should be properly specified. Yeah, go ahead. Go ahead.
Following this,
So the examination is over, right?
Yes, examination is over.
So, Dr. Archit, is there anything else you want to ask him? He has given you the examination, the per abdominal, per vaginal examination and findings. Archit, anything else you want to know?
Sir.
Yes, Bolo. You have to ask. It is your examination, so you have to ask everything.
No, sir, I can't think of anything else.
Archit, I'll give you one scenario that you are suspecting by history, you are suspecting a VVF, but on examination, you are not sure in your OPD. Okay, in your examination room, you are not sure. So anything else you can do? What would be your next line of like what is your thinking now? Okay, you are confused. It may be a stress urinary incontinence. It may be a VVF. It may be a ureterovaginal fistula. So what can be done?
Sir, we can assess for stress. A basic thing would be to ask the patient to cough or to walk around to see.
For stress test, what is the minimum capacity which should be there for bladder to perform a stress test? How do you do a stress test? You mean
Sir,
bony
you
stress?
sorry, sir.
You got my question. What is the minimum capacity of bladder? How do you perform stress test?
So for stress incontinence, so
Yeah,
we usually
there's a
fill up.
patient of X-ray. How will you perform a stress test, Boney's test? So these are very basic questions. You will ask her to have some bladder capacity. Then only you can do, na?
Yes, sir.
Yeah, so in this case, you cannot do because patient is saying that she cannot hold the urine.
Hold the urine.
Anything else you can do? Any two of you, anybody can answer. . There are very simple tests which can be done in OPD.
Dr. Ishwari. Dr. Ishwari, the another examinee. Is he there?
Okay, so I think this is the examination in OPD is very important in the VVF patient, because in this you can simply fill the bladder with a contrast with a methylene blue or a saline, and you can see with a simple gauge piece, you can see whether there is a VVF or not. At least this you can differentiate. Swab test is more complicated. That can be done in minor OT, but in OPD at least we can do this. Okay, you can. This was my question.
Archit, do you know the concept of the 2 swab test and the 3 swab test? You must have read it inside theory and so many times discussed in cases.
Yes, sir. Yes, sir.
So यही
3
पूछ रहे थे
swab
doctor.
test.
This is what he was asking.
Okay.
This is what he was asking. So why remain silent? You have to give the answer, na? This
Yes,
is
sir.
very common. अच्छा ये बताओ, in continuation with what Dr. Hemant was saying, say that the patient has got a VVF, but still she is able to hold and has got normal. In which condition can she have a normal voiding also in a VVF patient?
So a small supratrigonal fistula can give normal voids in between with leakage.
Why supratrigonal only? Why if it is a trigonal very small, 1 millimeter, 2 millimeter in the trigon, then she will not have normal voiding in between?
No, sir. A small fistula or a supratrigonal fistula both can lead to normal voids with leakage.
No, but why you are stressing always on supratrigonal? Even if it is a very small trigonal also, then also she
Yes,
can
sir.
have a normal voiding, na? So don't just say
Dr.
supratrigonal.
Dr. Nachiket is right. Any small fistula, wherever it is, the patient may have normal voiding. No need to say supratrigonal. But more importantly, what is the differential when the patient is voiding normally yet leaking?
Ma'am, it could be a ureterovaginal fistula rather
Yeah,
than a
it could be a
vesicovaginal fistula.
ureterovaginal fistula. Can it be a uterovaginal fistula?
Ma'am,
Utrovesical fistula? Have you seen iatrogenic utrovesical fistulas?
we have, ma'am.
Yeah,
In
so
the
you
sense of
have
the
to keep it
intramural.
in mind. So in this patient, hysterectomy is there, so it cannot be a differential diagnosis. But yes, if the hysterectomy was not there and some other procedure has been done for her, then you have to keep this as a differential. But ureterovaginal fistula is associated usually with what else? What other symptoms in history you didn't ask, pointing to a ureterovaginal fistula? To cut the time short, I'll tell you that you didn't ask for flank pain or any history of any PCN being inserted or any collection in the abdomen where a drain was put. So this will point towards a ureterovaginal fistula.
Yes, ma'am.
Any other differential which ma'am has said that patient normally voids but still leaking? So you said that it can be ureterovaginal fistula. Second, it can be simple.
Urethro, sir.
Yeah. What are the other differentials? There are two more things which can present like this.
Sorry, ureterovaginal fistula, which is a ureterovaginal fistula could also present like that, sir.
Can present like this. Can SUI present like this? Stress urinary incontinence.
Yes, sir, it can.
So these are some of the differential which you have to differentiate in your examination or investigation.
अच्छा अर्षित ये बताओ कि what is a pseudo fistula? Patient has a normal voiding pattern and she says that, but I am having some leak inside from the vagina and a little leak the whole of the day. So what is, and she has undergone a hysterectomy. So what do you understand by the term pseudo fistula? You're getting my point?
Yes, sir.
Hysterectomy was done. Patient is having normal voiding in between and a good holding, 200, 300 ml is bladder capacity. But however, she is saying that I'm having a little bit of leakage per vaginum and all my pads are wet and all my every time there is a little bit of fluid coming out. So on diagnosis of a pseudo fistula was made. So what is the pseudo fistula?
I'm not sure, sir.
Okay, so sometimes when hysterectomy is done while closing the vaginal vault, then sometimes, you know, the vaginal vault remains open and it gets epithelialized to the peritoneal cavity. So peritoneal fluid keeps on leaking, a little bit of peritoneal fluid, vaginal collection, and it's not a true fistula. So that is why it is known as pseudo fistula. And occasionally you see it, especially with laparoscopic hysterectomy. No, sometimes an opening is left in the vagina and the communication with the peritoneum.
Okay.
So, there was a question, Madam rightly brought about the utero-vaginal fistula. What is the other name for utero-vaginal fistula, vesical fistula?
Sorry, sir, can I get the question again?
So there is a utero-vesical fistula in between the uterus and in between the bladder fistula. So what is the name of that syndrome?
Sir, Yunus syndrome.
Yunus? यार कार क्रैश हो रहा है यार आज से तुम्हारा बिल्कुल ऐसा नहीं यार इट्स सिंपल केस यूसुफ सिंड्रोम
Yusuf
syndrome
syndrome.
थोड़ी ना होगा Yusuf will get angry that you are giving credit to Yunus. So what is Yusuf syndrome? These are very simple questions. All my seniors and my teachers and my friends, they are very normally asked in the exam in the case presentation. What is Yusuf syndrome?
Sir, it's a combination of suprapubic pain with hematuria with infertility.
Sorry, there is infertility and you're cracking up.
Sir, amenorrhea with
Anuria.
cyclical hematuria.
Anuria.
Sir, amenorrhea.
Amenorrhea. Okay, yes, amenorrhea. Secondary amenorrhea with cyclical hematuria.
With cyclical hematuria or menuria. And
yes.
So there can be continence
with infertility also. Achha, other condition in which you can get cyclical hematuria, just like Yusuf syndrome. What other condition can you get cyclical hematuria?
So bladder endometriosis can present.
Yes, very good.
Hematuria.
Very good, very good.
So we need to finish in next 5-10 minutes.
Yes, so what's your diagnosis?
Sir, ma'am, at this point, it looks like a vesicovaginal fistula, but I'd like to confirm it with imaging of the upper tract, if possible, to rule out a secondary ureterovaginal fistula with no attempts at any prior repair.
What imaging do you need? Or do you want to go ahead with any biochemical investigations first?
Ma'am, we try to, RFT for the renal function, following which we can do a contrast study, either an IVP or a CT urogram.
See, in an exam, it cannot be IVP or cysto intravenous urogram. You have to give one answer. Do you think both of them are comparable and both of them are equivalent?
No.
No.
No, ma'am.
So then what are the disadvantages of IVP?
Ma'am, an IVP doesn't give you anatomical delineation the way a CT would.
No, but if it is done properly, why should it not give you? See, IVP images only the genitourinary, not the genito, only the urinary system. While a CT will tell you about things at the vault, it will tell you about the other structures nearby, whether there is any involvement of the nearby organs like the ureter, or if there is a malignancy, means not in this case, whether any residual malignancy, any recurrent growth happening there. So all these things are an advantage. So you, when you're telling in an exam, you choose one investigation. You can't say or. Otherwise, then these questions will follow.
Then a CT urogram would be.
Also, in a CT urogram, Dr. Archit, you must be having CT in a facility in AIMS, no? So you can get the reconstruction
Yes.
done, the reconstruction can be a lateral reconstruction. A very good radiologist will also can tell you the site of the fistula. He can tell you about the reconstruction of fistula, length of the fistula, obliquity of the fistula, about the vagina, whether there is urinoma inside the case of uretrovaginal fistula. There are so many advantages of a CT urography compared to an IVU that you should only one good investigation, good radiologist. He will tell you everything. He will even tell you about the obliquity. He will show you inside the reconstruction that this is where it is opening into the vagina. So one investigation that is the best, I think, is the CT urography. If maybe other people they have something, I think CT urography is good enough, and there is no difference between CT urography and MR urography. Personally, I feel.
I just want to ask one thing. Why do you want to have a upper tract imaging? That is the importance of your history. Do you suspect a uretrovaginal fistula in this case?
No, so it's not likely, but
Likely, why you can't just have ultrasound, and if they don't show any dilated ureter, you can go ahead. The importance of a good history lies in your investigation. So that will help you in your further investigation. If it was a simple hysterectomy, simple post, that is what Dr. Nachiket sir was also saying. You should take a very proper history, the part of injury period. Okay, if it was there's something, drain was put, abdominal pain, some drain was coming out, leakage was very severe, but some things which guide you that they may be some associated, it was a very severe injury. So they may be associated uretrovaginal fistula. In that case, you will definitely want a CT urography. But in a simple obstetric fistula, I don't think you can just go ahead with the ultrasound, because there is one golden investigation which you will have to do, that is a diagnostic cystoscopy. Okay, that you can do everything on that. So you can just save the cost. We are all in government setup. We can just save the cost. In an uncomplicated history, in a simple history, simple VVF, you can just go ahead with the ultrasound and you can do a cystoscopy examination. You don't need any other investigation. We used to do a T-swab test, very fancy test was there. Now nobody is doing, because the cystoscopy is available. So that is the importance of a good history. You can minimize your investigation.
We'll have the last 5 minutes, sir, please.
So will you go ahead with cystoscopy? You got a ultrasound, CT scan, everything you have done. Whatever one of these things you have done, it is showing up. What basically you want to see upper track in that? You want to see an associated uretrovaginal fistula. What you are doing your imaging, like ultrasound, CT urography or MR urography? What is your primary purpose for doing imaging?
To see if there's any dilation of the
basically you want to see upper tract.
side.
You want to see upper tract.
Yes, sir.
You are not doing the imaging for fistula. For fistula, what is the gold standard imaging? What is the gold standard investigation?
Sir, MCUG with lateral view is.
You don't have cystoscopy?
Sir, imaging, you said.
Sorry. I just want to what gold standard you can do. So
a cystoscopy.
I think MCUG is not an answer, definitely. Unless if you are able to fill a bladder, then she will void.
Yes.
MCU is micturating cystourethropy. Anyway, what Dr. Goel is saying is absolutely right. If ultrasound is normal, there is no need for further these things. If you find a fistula on cystoscopy very close to the ureteric orifice, you may do an RGP in additional. So you can cut down. Okay.
So I think that is, the ma'am has also given the same message. Imaging is for upper tract, cystoscopy is for fistula. Most 99.9% of the cases that will do. Don't complicate
And
with
MCU is not an answer. Also, this is one message.
Yes. So will you have you done cystoscopy?
Yes, sir.
Yes, sir.
Tell us the finding of cystoscopy.
Cystoscopy was suggestive of supratrigonal defect that is present on the posterior wall of bladder of approximately 1 centimeter in the midline, and the mucosa is healthy, and the defect is approximately 3-4 centimeters away from both the ureteric orifice and the rest of the bladder cell was normal.
He has given you the best possible findings for the simplest case. Ureteric orifices भी दूर हैं, बहुत दूर हैं, supratrigonal भी है.
How you are sure? How you are sure it is a vesicovaginal fistula? I am not sure. There is a. I am saying it is a diverticulum. What you are showing? I am not convinced. Because in VVF the bladder is not distend. I am not sure it is a VVF. It is a bladder diverticulum. What you are showing? The bladder is properly distending. You can see a defect. It is a bladder diverticulum. Otherwise, in VVF, bladder will not distend.
So we could do a vaginoscopy in the same setting. The other option is if we pass a wire
that is
through
important.
the
When somebody is saying cystoscopy, you should give a proper
the
examination in your minor OT under anesthesia or without in a local anesthesia. You should say that it is examination under local anesthesia. You have done cystoscopy, vaginoscopy. Proper finding should be there. Only on cystoscopy you cannot be sure. Otherwise, you say that when you are doing cystoscopy, irrigant fluid is coming out from vagina. Something you should say, na. Give a proper finding. Okay, you can modify what. Yeah, say.
Now
so
these
I
are
also
the
wanted to ask
findings. Now these are the findings. So अब क्या करोगे? This is because I think that Samir sir, how much time is left? 5 minutes.
No, the 5 minutes was 5 minutes back. So now we are almost out of time. So maybe last
Just
1 or 2 minutes.
just tell in 2 minutes what you are planning to do.
Sir, I just also wanted to check whether there's pyridium efflux from both the ureteric orifices. And
there was a good efflux. No, your operative plan.
Sir, it's the first time 1 centimeter fistula is away from the ureteric orifices. I would still try to give a transvaginal repair, an attempt at a transvaginal repair.
Okay. How will you do it?
What Dalila sir was telling you, that during examination it's very important to see about the vagina, whether the vagina has got a good capacity, whether you can do a transvaginal repair. That is why he was saying at that time. Because if you are doing
Sir,
it,
no, sir, it was mentioned, sir. Vagina is roomy, there's no fibrosis.
आपने नहीं mention किया ना,
And the
लेकिन
mucosa
सर ने mention किया ना उसको.
So
because many times
what repair you will do?
Sir, a 3-layer repair. I don't think this would require an interposition
Name of the
flap.
repair. Arjit, name of the repair. Name of the repair. What flap you can use? Name of the flaps. This thing, if you can answer.
A flap is, sir, we would use a Martius flap, which is a layer. I mean, if required, I don't think it's required in this case, but otherwise a Martius flap, which is based on the labial.
That is why I asked you, because it is a vault fistula. You said that it is present in the post-hysterectomy vault fistula. Never ever you will be able to use a Martius flap in this case. It will be 4 to 5 centimeter away from the orifice. You will have to use a omental or peritoneal. For a very high supratrigonal fistula, it is. You said that in examination vaginal, it is in the vault. That was your finding, no? It is not in the anterior vaginal vault. The remaining vault of the vagina, the fistula is present over there, no?
Okay. Yes, sir.
So your Martius flap will not go there. It is some abdominal flap, either omentum or peritoneum. That will be required. So you should be very careful about your flaps.
Also, can I make one more comment here? Is the patient very obese? Is the patient obese? What is her body weight and BMI?
Dr. Goel, is the patient obese or is the patient, what is the build of the patient?
She's thin built, sir.
Thin built. Okay. Is that point important when you are choosing to do a transvaginal repair?
So,
no.
Positioning the patient in lithotomy might be difficult.
Might be difficult.
She's
yes.
very obese.
But even in a lithotomy position in obese patients, there are a lot of abdominal fat, abdominal viscera. It keeps coming, putting pressure on the vagina. So you need to be very strong with the retractors. Then only you can perform such a high fistula closer transvaginally. Otherwise, they better dealt transabdominally. So the point we are trying to make is if you choose for a transvaginal repair, see that whether you'll be able to reach to that point or not. Otherwise, it becomes a lot of difficult surgery unnecessarily.
Yes.
I think, sir, we have run out of time. So rather than asking questions, I would request the examiners to make final comments and then we'll close this session, sir. Dalila, sir, starting with you, sir. Your final comments and anything which is left so far you would like to emphasize.
No, I think nicely done. No, good discussion was done and nicely all aspects have been covered. In exam, we like to discuss the options for surgical closure. Vaginal, transvaginal, transabdominal, what are the indications of omental interposition, what are the indications of peritoneal flap coverage, when do you do which one? So those points should also be knowing. The candidate should be knowing all those technical details of the surgical procedure. Because for the want of time, we have not been able to cover these points. Please read those issues also.
Yeah, and maybe
Nachi, any final points which you want to emphasize? You have to leave, I believe.
Yes, sir. Thank you so much. I just want to tell Archit that you will definitely get this, case inside your exam. Either it is going to be inside your MCH exam or DNB exam. You didn't do the best, you didn't do the worst, but there's, I think that this is a very common case, and prepare it properly so that, you are going to be benefited from what you have been heard today. And thank you for putting up your hand and taking up the case. I really appreciate that. Thank you.
Yeah,
Thank you,
so
sir.
message is
Sujata ma'am, any final comments?
don't get overwhelmed by the situation. So this actually activity is meant for that only, to give them a experience of going through the examination process. Yeah, madam.
Sujata ma'am, yes.
And I think I agree with him. You did fairly well. The mobility of the fistula and ability to bring it in view is the most important thing. Otherwise, you'll have to use a jackknife position for if you want to do it vaginally. You need to know the names of the vaginal repair. There are 2-3 names to it. You need to know abdominal repairs also, and laparoscopy and robotic repairs also. So we have to keep all these things in mind while answering. Definitely, I think if we had more time, we could cover more. But thanks very much to the North Zone for inviting me, and I'm obliged. Thank you very much.
Thank you, ma'am. Thank you so much. Hemant, any final comment?
Only, sir, just one thing I will just tell them that for the most important part of the fistula repair is the first layer. If that is defective, there will be 100% leakage. Second, third, fourth layer will only increase the success rate. So first layer is very important. Second thing is flap. They are always confused. If you can bring a flap from downward easily, that are trigonal fistulas or bladder neck fistulas. So you use a Marshall flap, lower flaps. And if it is a vault fistula, higher fistulas, you always try to take peritoneal upper flaps, peritoneal momentum. So that will be easy to bring. So that's all, sir. Baki rest, he has done best for a level of resident. Thank you, sir. Thank you for inviting us.
Thank you. Thank you very much. Thank you. So thank you all the examiners and the presenter as well as the examinees. We move on slightly behind schedule. We move on to the journal club, and I will invite the experts, Dr. Shivam Pridashi sir, Dr. Pamposh Rena sir, and Dr. Anil Alain sir. And the journal would be presented by Dr. Jitendra from KGMU Lucknow, and the discussion part would be by Dr. Nitin from RML Delhi. So Dr. Jitendra, you can please start sharing the screen, and I invite the experts to take over.
Yes, sir. Is it visible, sir?
Yes, it is visible. Please go ahead.
Very good morning to all. I am Dr. Jitendra Yadav, a senior resident, King George Medical University, Lucknow. I'll be presenting a journal article titled New Protocol for Renal Collecting System Sterilization with Antibiotic Irrigation During Lithotripsy in Retrograde Intrarenal Surgery, a Prospective Comparative Study. This article was published in World Journal of Urology on 10th April 2024. Journal issue was volume 42, article number 229. Impact factor is 3.4 according to 2022. And the place of study was Ankara City Hospital, Ankara, Turkey. And the time of study was January 2022 till August 2023. Coming to the introduction part, RIRS is a safe and effective minimally invasive procedure for kidney stones. And according to EAU guidelines, RIS has been considered as the first line of management for stones less than 2 centimeter in size. And post-operative infections constitute a major chunk in complications. 50% of all are due to post-operative infections. And even if the urine culture is negative, it has been reported that post-operative fever has been reported up to 14.6%. The complication rates are increased if there is bacterial production in the stone or if the renal pelvis culture was positive. There has been many studies which has conducted preoperative prophylaxis and various results have emerged, but there has not been any study which states that we can sterilize the renal collecting system. So to minimize the infection complications, it has been attempted to produce a solution for sterilization of the urinary system. So the aim of this study was to provide a collecting system sterilization in lithotripsy with the use of antibiotic irrigation solution. Coming to the methods, it was a prospective comparative study. Total 102 patients were taken, and the study was done from January 2022 till August 2023. In inclusion criteria, all the patients were taken who had kidney stone and no ureter stone were there. They excluded the patients who had stent or nephrostomy tube, whose serum creatinine was more than 1.5 mg of deciliter, and who had pathological ureter stricture, or if they had any history of radiotherapy, or they had solitary functioning kidney, and pregnant ladies were excluded. Basic data they recorded was age, gender, BMI, ASA scores, size of the stone, volume of the stone, density of the stone, and the Seoul National University Renal Stone Complexity Score was taken into consideration. Now coming to the surgical procedure, all the patients who were taken in study 1 week prior urine culture was taken, and 1 day before the surgery, all the urine culture reports were tested, and they all came out to be sterile. Prophylactically, 2 grams of ceftriaxone was given according to the renal function. All the surgeries were done in general anesthesia. Lithotomy position was made. 80 mg of gentamicin was dissolved in 3 liters of normal saline with a concentration of 26.7 mg per liter versus standard 3 liter normal saline we use generally. So the semi-rigid ureteroscope of size 6.5 and 8.5 French were introduced into the bladder. Bilateral ureteric orifice were visualized, and a guide wire of 0.035 inch was introduced into the ureteric orifice. Then semi-rigid ureteroscope was reached till the renal pelvis, and ureteral access sheath was placed. A sheath was of size 9.5 internal diameter and 11.5 external diameter. Those patients in which ureteroscope could not be negotiated, 4.8 French stent was placed and the operation was postponed. And no patient underwent balloon or serial dilatation if ureteroscope could not be passed through. Procedure was done with flexible ureteroscope of size 7.5 French. There were few cases both in antibiotic group and normal saline group, 6 patients and 7 patients in standard group, in which UAS could not be placed. So the procedure was done with flexible ureteroscope passed directly over the guide wire. And at the end of the surgery, 4.8 French DJ stent was placed in all the cases. The procedure was done using Holium YAG laser 273 micron, and the dusting setting was applied, setting 0.3 to 0.5 joules at 20 hertz was placed. Post-surgery, after 3 weeks, DJ stent was removed on OPD basis. At 4 weeks, they asked the patient to get an NCCT to look for stone-free status. Stone-free status was considered if there was no residual stone on CT or if there was clinically insignificant stone, less than 2 mm of size. All the procedures were performed by only 2 surgeons who had experience of more than 200 urinary system stone operations per year. Few definitions which they told were like post-operative fever. They considered if the body temperature was more than 38 degrees Celsius within first 48 hours of the surgery. Urinary tract infection was considered if urine culture was positive and blood culture was also positive. SIRS was taken into account if at least 2 of the following were there, like hyperthermia more than 38 degrees Celsius or hypothermia less than 36, respiratory rate more than 20, heart rate more than 90 beats per minute, and WBC count more than 12,000 or less than 4,000 was taken. Sepsis was considered if SIRS was there with confirmed or suspected infection. All the patients were evaluated with respect to operating time, stone-free rate, post-operative fever, UTI, SIRS, sepsis, tachycardia, tachypnea, abnormal WBC count, admission to the ICU, change in creatinine on post-op day 1, length of post-op hospital stay, rehospitalization within 30 days of RIRS. All the patients were hospitalized for at least 1 night of observation following the surgery. Lab studies were made on the morning of post-operative day 1. The monitoring of vital signs were continued in the recovery room immediately after the surgery and after that into the ward. Coming to the statistical analysis, continuous variables were stated as mean plus minus standard deviation if the distribution was normal, and as a median interquartile range if the distribution was not normal or skewed. Categorical variables were stated as number and percentages. Pearson chi-square test and Fisher exact test were used for comparison of categorical data. P-value of less than 0.04 was accepted as the significant value.
Dr. Jitendra, little faster, please. Little faster, please.
Result total 131 patients were taken initially, out of which 11 were excluded. 8 had previous DJ stent placement, 2 had solitary kidneys, 1 had a raised serum creatinine value. 5 did not accept the operation. 4 did not attend the follow-up examination, and in 9, semi-rigid ureteroscope could not be negotiated. So finally, they had only 102 patients, out of which 51 were given antibiotic irrigation and 51 were given standard normal saline irrigation. So all the patients were discharged on post-op day 1, except for the patient who had fever, UTI, SIRS, and sepsis. Acute renal failure was not seen in any of the patients. Maximum operation duration was 90 minutes. There was no requirement of any blood transfusion or any major complication was not seen like ureteral perforation or avulsion. So this is the table showing demographic characteristics they had taken. And none of the characteristic was significant. The early post-operative complications, stone-free rate, and intraoperative post-operative 1 month follow-up data. So out of these, only 3 values were coming out to be significant: presence of fever, SIRS, and post-operative hospital duration in the patients. And p-value was exactly 0.05 for all the 3 things. Rest all things were non-significant. This is the chart showing comparison between the antibiotic irrigation and normal irrigation. In all the things like post-op fever, UTI, SRS, sepsis, tachycardia, tachypnea, WBC, antibiotic group was proven to be superior. Coming to the discussion part. So due to increasing stone prevalence, it has led to the increased ureteroscopy. Ureteroscopy has small risk of major complication, although infection complications are at increase despite of small major complications.
Then maybe go directly to the conclusions and discuss
coming to the limitations of the study was stone composition was not examined, as stone fragmentation was not extracted. Intraop stone samples could not be obtained. Infected stones such as struvite stone can increase complication rate. Further limitation which was stated was they had not taken renal pelvis culture, and stone culture into consideration. And they did, the reason they gave was that it may lead to bias due to false negative result in the group where the antibiotic solution was used from the start of ureteroscopy. And it was single center study. It cannot be generalized. And long-term studies with larger sample size are required to make it a standard. Coming to the conclusion, a new protocol is presented in the study for sterilization of the renal collecting system using antibiotic irrigation during lithotripsy in RIRS. Due to the ease of application, it can become the part of standard RIRS. And this antibiotic irrigation protocol is a promising method which can be used safely and effectively to reduce infection complications like post-op fever and SIRS. And coming to the critical appraisal, in the title, comparative group and possible outcome is not indicated. And I am sterilization term they have used. I don't think we can sterilize a live tissue. And scientific basis and rationale of using gentamicin and its dose for irrigation is not clearly explained in the introduction part. Objectives clearly not stated in the introduction. And how did they take 102 patients as sample size? It is also not mentioned. And how did they divide the patient? And method of study, subject allocation to the different group is not mentioned. Complete definition of pre-specified primary and secondary outcome measures, including how and when they were assessed, are not mentioned post-operatively. Post-operative evaluation after POD1, follow-up and data collection not mentioned very properly. Thank you, sir.
Keep your slides on.
Yeah.
So
over to the experts, please.
Yeah. Thank you. There is a discussant also, right? Somebody who is going to discuss?
Yes. Yes, sir.
Who is it?
Sir, I'm Dr.
from
Nitin.
yeah. Dr. Nitin. Okay.
Yes, sir.
So have you made some slides or we will just start a discussion?
No, sir. I'll just answer your questions directly.
Okay, fine. With the permission of my co-chairpersons, Dr. Anil.
Yeah, go ahead, Shivam. Shivam, go ahead.
Yes.
You go ahead, then I'll come up to you.
Right. Thank you. So Nitin, what do you think about the study? Your critical appraisal, and then I will ask you questions.
The idea of using gentamicin as an irrigation seems a reasonable option because there have been studies in the past which use gentamicin for intravesical installations to prevent recurrent UTIs. Many such studies are seen on the literature.
Fine. Anything else? Yes. But we have to be very brief. We're already short of time. Anything else you want to say?
There's one more study which is similar, which was used in PCNL. Same concentration of gentamicin was used, and the results of the study were promising. The fact that in this study the sample size and there's no randomization of the patient, just that is the issue with the study, I think.
No. Okay. So this was just a comparative study. No randomization was done, right, Jitendra?
Yes, sir.
Fine. So you think gentamicin, they allowed till 1.5 milligram creatinine value. Do you think this is okay or in every patient, or because sometimes the range is till 1.2, 1.5 is a borderline CKD patients, right? So
Yes,
do you think gentamicin is a okay drug for patients who
Yes,
have
sir.
1.5 creatinine?
I think it is okay because we are not using it intravenously. It is being used for sterilization in the irrigation solution. So in previous studies they have measured the concentrations of the gentamicin in the serum after installation and irrigation, and they have found that the serum values are not exceeding to that extent because
Why do you
renal
think
toxicity.
gentamicin is it just an empirical kind of a antibiotic they have chosen, or it should be based on some kind of logical background?
Yes,
Why gentamicin?
as we all know that gentamicin is very good, has a very good action against
So what do you
gram-negative.
think? how do you choose empirical antibiotics? In your ward and in your setting, how do you choose empirical antibiotics?
Basically, it is as per the institutional policy and the type of infections we get. And it is from the review by the microbiologists. They take cultures from the hospital and wards, and we see a pattern of which infections are common in the hospital settings, and as per that hospital policy, the antibiotics are decided.
Right. So you should have an antibiotic policy. You should have an antibiogram of your own before you decide which antibiotic would be suitable in such patients. So
yes,
gentamicin would be. So I would ask Dr. Anil to go ahead, and then I will ask.
Yeah, Nitin, apart from the fact that gentamicin was used empirically, even the dose at which it is used, there is no study which would say a 26 milligram per liter is an effective dose. The dose could have been higher, lower. So another part of the study could be using different doses of the gentamicin, the same irrigation fluid. One thing which both of you missed in the one of the most critical part of causing infection during RIRS is the pressure at which the irrigation fluid is being used. So there was no mention of the height of the irrigant. There was no mention whether any pressure injector was used or not.
Yes, sir.
And also the degree of manipulation or they kept a time period as 90 minutes.
They had kept the normal saline at meter above the patient level in all the patients.
So they had kept it 100 centimeter. That is written in the.
It was not mentioned by you. And secondly, was any pressure injector used or not? Periodically or constant pressure pump, because that would be the most critical part of inducing infection. So irrespective of whether we are using an antibiotic or not, the pressure at which the fluid is going in would be for opening up the venous channels and causing backflow of whatever bacterial colonization is of the PCS. Secondly, another factor which could be there was no study of the degree of dilatation of the PCS. A more dilated PCS or a compacted PCS will also impact the pressure of the same height of irrigation we are using, the same tubing we are using, but the degree of the PCS dilatation would also make a difference of the intrarenal pressure, which anyway is a very critical part, as I've been repeatedly saying.
I think, sir, that
Rishi,
they have used the modified. They have used the modified Sewell score or Stone score, and that includes all the things that we are mentioning here about the dilatation of the pelvis and hydronephrosis and the difficult anatomy. They have not mentioned it separately, but they have classified the stone as per the modified Sewell Stone scores classification, and they have randomized. Allocated in the two groups.
Do you think the exclusion criteria was okay, or they should have added some more exclusion criteria before generalizing these groups? So don't
Jitendra,
you
can you show me the exclusion criteria?
Yes, sir.
That you must have remembered, right? So what do you think? It is okay?
Yes, sir.
Okay, so don't you think other associated comorbidities like diabetes can influence the rate of infection? Don't you think the age of the patient can influence? Don't you think the age of the patient can influence? Don't you think the hospitalization of the patient before surgery can influence? So there are so many factors which can influence the postoperative infection.
Even an outflow obstruction of the lower tract.
Yes. So if the patient was catheterized or not beforehand, that also is important. So there's so many things which will come in play, right? So I think the exclusion criteria was probably not in perfect in that sense. Anything else?
Sir, can I make a comment?
Yes, Rishi, please go ahead.
Yeah. So as already pointed out, the issues with this paper, the most important one being that it is not a randomized study. So they have not specified how did they decide which patient to give which grouping. And secondly, if you look at the endpoint that they have measured is the fever and SIRS. and predominantly it is the fever that they have focused on. And if you go to the results, you would see that it is the same set of patients who there was, I think, 6 patients who developed fever in one group, and the same set of patients were grouped as SIRS. So it was predominantly the fever which is driving the results. It is not the SIRS which is driving the results here. So in terms of the tachycardia, tachypnea, sepsis, abnormal WBC count, there was no difference. So all that we are looking at is only the fever in the post-operative period. And that too with a antibiotic which is used at a very low dose, which is not absorbed in the systemic circulation, because as we all know that amikacin gentamicin group does not get absorbed because of their ionic nature. So it has no role in terms of the prophylaxis beyond the surface prophylaxis, and the term that they have used for the antibiotic usage as sterilization, I think that is grossly wrong. Antibiotics are not sterilizing agents. They have a very limited bacterial cidal activity, and that too only on the bacteria which are growing, not on the bacteria which are in biofilms, not on the bacteria which are in form of spores, and certainly not on atypical kind of bacteria. Very limited antibiotics affect the atypical bacteria. So therefore, all in all, this study is not definitely, I don't think it is a practice changing study as of now, particularly because they have not even mentioned the irrigation volume and the duration of surgery. They have not even evaluated for that.
Exactly. The duration of surgery, stone size, everything would matter in these patients. And definitely, we have studies which have shown that pelvic urine culture and the stone culture can actually guide you the treatment, that type of antibiotic that you would like to use in patients who have the chance of more infection. In fact, we in our center, we did a study, and Dr. Nachiket was guide, where we did a stone culture in all of these patients. And most of the times, the urine culture and the stone culture and pelvic urine culture will be discordant. So they have different set of bacteria altogether. So the midstream urine culture may not actually guide you the treatment also. So in that way also, I think probably stone culture and pelvic urine culture are more important.
So can I?
Yes, Dr. Pamposh is there. Dr. Pamposh?
Yes.
Yeah, Dr. Pamposh
is not there, right? So
He's
anyway,
here.
yes, Dr. Apan, you wanted to say. Dr. Pamposh is there. Pamposh, please go ahead.
Actually, in this article, they have not used any pressure injector. They have used gravity only.
Yeah.
100
That's right.
centimeters, they have kept the height. And I just want to mention that during our residency days also, we used to use gentamicin in irrigation, in fluid, or in hypospadias repair, in VVF repair. One of the advantage of using gentamicin is that it is very cost effective and covers gram-negative spectrum. Perhaps this may be the reason that they have used gentamicin in this study.
Yeah. Yes, Dr. Pamposh, thank you. But nowadays, the best way to do is to have an antibiotic policy, know exactly your own antibiogram, and choose your own antibiotic. That is the best way to go ahead. Yes, Dr. Apul wanted to say.
Thank you, sir. Dr. Apul wanted to make a point. The last comment, please.
Jitendra, can you go back to the table?
Yes.
Actually, see, the biggest problem in this study is that the adverse event in one group, only one patient had. So the numbers are too small actually. 6 patients in one group and 1 patient in another group. So you cannot compare. How do you compare data? There's in antibiotic irrigation group, there's only 1 patient. So the groups are uneven. You need to have bigger studies. At least you should have at least 10 patients in each group to make it comparable. So the number of patients in this group is too less.
No, the total number of patients are much higher. The only thing is
only one patient had an adverse effect.
Yes.
But
So,
for many factors, it is an underpowered study and should
Underpowered.
not. Yes, it's very underpowered.
So we do not know the exact how the sample size was also taken. So Yes. That is again a problem. We do not know the seed article and other things which.
Okay, sir, I think we had a very good discussion. I thank all the experts and the presenter as well as the discussant.
Thank you. Thank
So,
you.
thank you, sir.
Thank you.
Thanks, sir. Does anybody want to say anything? All right,
Yeah,
we'll move on. I mean,
thank you. Yes.
yeah,
go ahead.
Dr. Rishi, you wanted something?
No, move on, please.
Yeah. Okay. All right.
Thank
So
you.
move on to the next journal, and this is the presenter is from AIMS Rishikesh, Dr. Siddharth, and the discussion part will be done by Dr. Parth from Safdarjung, Delhi, and the chairpersons for this session are Dr. Prashmanu from AIMS Delhi, Dr. Ravi Mohan from PGI Chandigarh, and Dr. Sanjay Sureka from SGPGI Lucknow. So excellent panelists for a topic related to uro-oncology, and I hope we'll have a good discussion. So Dr. Siddharth, you can start sharing your screen. I invite the experts to take over, please.
Sir, are my slides visible, sir?
Yes.
Yes. Go ahead.
Good morning, respected faculties. Today we'll be discussing an article. The title is Downstaging and Survival Associated with Neoadjuvant Immunotherapy Before Radical Cystectomy for Muscle Invasive Bladder Cancer. This article has been published in 2024 in the Journal of European Urology, which has an impact factor of 8.2. And the author is Dr. Jacob et al. Now, as a brief introduction, muscle invasive bladder cancer in itself is a high-risk disease, with 60% of the patients dying of the disease within 5 years of diagnosis. Cisplatin-based neoadjuvant chemotherapy, followed by radical cystectomy, is a standard guideline and improves the overall survival in comparison to radical cystectomy alone, and is the standard of care. Up to 50% of the patients, however, who are indicated for cisplatin chemotherapy are ineligible for the said treatment. Owing to a more favorable toxicity profile, immunotherapy has emerged as a promising neoadjuvant alternative for patients who are with localized muscle invasive bladder carcinoma. Now, these are a mention of the few studies that have been previously done, which are single-arm clinical trials for neoadjuvant immunotherapy, which includes PURE-01 trial, which was based on pembrolizumab, which is a PD-1 inhibitor, which showed 37% complete pathological response in patients undergoing radical cystectomy on histopathology specimens. Similarly, Abacus trial, which was based for atezolizumab, which is a PD-L1 inhibitor, showed a 31% complete pathological response on pathological staging after radical cystectomy. And Nabucco trial, which showed nivolumab and ipilimumab, which are PD-1 and CTLA-4 inhibitors, having 46% pathological response. Now, the objective of the said study was to compare the rates of pathological downstaging and overall survival between the patients who were receiving neoadjuvant immunotherapy, chemotherapy, or no neoadjuvant therapy at all. Now, the data source and study population. The source of the study has been from the National Cancer Database and incorporated patients from 2014 to 2019. And the study was conducted using de-identified data and was following the stroke guidelines. The inclusion criteria was mentioned as that patients who had muscle invasive bladder carcinoma with non-variant urothelial carcinoma histology without metastasis or lymph nodal status more than 1, or who underwent radical cystectomy with a complete staging and demographic data available were included in the study. Those patients, however, who received clinical trial or experimental protocol treatment were excluded from the said study. Also, the year 2014 was taken as the starting year because that was the year that US FDA approved pembrolizumab for intravenous use for muscle invasive bladder cancer. Now, here are the variables and definitions in the study that were used. Neoadjuvant chemotherapy was defined as multi-agent systemic chemotherapy, which was initiated within 6 months before radical cystectomy. Adjuvant chemotherapy was started within 3 months after radical cystectomy. Neoadjuvant immunotherapy was defined as initiated within 6 months prior to radical cystectomy. High-risk surgical pathology was defined as PT3N0, PT4N0, or any P with lymph nodal status positive. Pathological downstaging was assessed as PT0N0 or T less than 2 N0 disease on histopathology. Now, patients were stratified in 3 groups: those receiving neoadjuvant immunotherapy, those receiving neoadjuvant chemotherapy, or no neoadjuvant therapy at all, and were classified in 1:1:1 nearest neighbor propensity match without replacement was done. The baseline variables which were used to match these three groups included age, sex, race, Charlson comorbidity score, the facility type in which they received the said treatment, their year of diagnosis, the clinical T stage and clinical N stage. Now here is the result of the study. It shows that the initial study incorporated 7,21,733 patients from 2004 to 2019, of which 7,03,000 patients were excluded from the study for the following reasons. 3,89,000 patients were diagnosed prior to 2014, which were excluded. 2,46,933 did not undergo radical cystectomy and were excluded. The data was missing for approximately 30,000 patients, which were excluded. 23,000 patients, 340 were found to be metastatic at the time of diagnosis. 8,926 patients had T less than 2 or lymph node status more than 1. And 3,992 patients had non-urothelial malignant carcinoma histology, which were excluded. 159 patients were receiving clinical trial protocol, hence excluded from the study. Considering this, the total population that they incorporated was 18,483 study population. Amongst the said population, 8,418 patients received neoadjuvant chemotherapy. 280 patients received neoadjuvant immunotherapy, whereas 9,785 patients received no neoadjuvant therapy at all. The follow-up of these patients were done for 5 years with a large with a median follow-up of 28.7 months. Now, this is a graph showing that the proportion of patients who were receiving neoadjuvant chemotherapy improved from the year 2014 to 2019, which is 35.9% initially to 49.6%. Similarly, the proportion of patients receiving neoadjuvant immunotherapy improved from 2014 to 2019 from 0.04% to 3.6%, whereas the patients who did not receive any neoadjuvant therapy reduced. The patients who did not receive neoadjuvant therapy tend to be older and had higher Charlson comorbidity scores. After a 1:1:1 nearest neighbor propensity match, the total sample size that they included was of 840 patients with 280 patients in each arm, total 3 arms. These are the variables that they had matched. As depicted here, the total size before matching was 18,483. The match sample was 840. All the factors including age, gender, race, the comorbidity status, the facility in which they received the treatment, the year in which they received the treatment, and the clinical T stage and clinical N stage were matched prior to all of the study. The only significant factor was the pathological downstaging based on the radical cystectomy specimen data. Sir. Now, the study demonstrated that amongst the comparison for no neoadjuvant therapy versus neoadjuvant chemotherapy, there was significant pathological downstaging of the disease to PT0 as well as PT less than 2 disease. Similarly, the study demonstrated that in comparison to no neoadjuvant therapy versus neoadjuvant immunotherapy, there was significant pathological downstaging to PT0 or PT less than 2. However, in the arm comparing neoadjuvant chemotherapy with neoadjuvant immunotherapy, there was no significant p-value difference between the two arms, showing efficacy amongst both the arms of neoadjuvant chemo as well as neoadjuvant immunotherapy with similar pathological downstaging. Now, this is a Salkowski diagram showing the same, that of the 280 patients selected in each arm who received non-neoadjuvant therapy, neoadjuvant chemotherapy, and neoadjuvant immunotherapy underwent radical cystectomy, what was the pathological downstaging of the said disease. The second part of the study analyzed the survival analysis in the said patients. It showed benefit in survival analysis at 36 months of duration in patients who had received neoadjuvant chemotherapy versus no neoadjuvant therapy. Similar outcome was there in neoadjuvant immunotherapy versus no neoadjuvant therapy with a benefit at 36 months. However, there was no significant advantage between neoadjuvant chemotherapy and immunotherapy, hence showing equivalency of the same. This is a survival probability index that they had given, analyzing up till 60 months of data. However, the survival that they had mentioned previously was up till 36 months. Now, this is an exploratory analysis of the study. They had done for the survival data, they had included 1,373 patients. The data that they came out was based on the 466 patients who did not receive any adjuvant chemotherapy post-surgery and were not required for any adjuvant chemotherapy, and 907 patients who received adjuvant chemotherapy, which was required based on their histopathological stage, versus those patients who received neoadjuvant chemotherapy or immunotherapy. Now, the data showed that there was overall similar rates of pathological downstaging and overall survival between the neoadjuvant immunotherapy and neoadjuvant chemotherapy. A major benefit of the immunotherapy group was there in the elderly and medically complex population because of having a more favorable toxicity profile. Similar results were demonstrated in the IMvigor 130 trial, where there were substantially lower rates of treatment-related adverse effects secondary to atezolizumab monotherapy arm than in the chemotherapy arm. And the rates of pathological complete response associated with neoadjuvant immunotherapy and chemotherapy in the study were comparatively lower as compared to the previous demonstrated clinical trials, with pathological lowering up till 25% of PT0N0 versus the 30 to 45% pathological downstaging done in previous clinical trials. Coming to the limitations of the study is having selection bias involved because of the retrospective analysis done. The study also identifies patients who had received systemic immunotherapy might theoretically have received therapy such as interferon alpha or high dose of interleukin 2 included in the immunotherapy group, which are not standard of care in immunotherapy anymore. And not all patients in the neoadjuvant chemotherapy group received cisplatin, which is considered as the backbone of neoadjuvant chemotherapy for muscle invasive bladder cancer. There was also a lack of information on the renal function or specific comorbidities in patients who were considered cisplatin eligible or ineligible in these groups. The patients who had received neoadjuvant therapy but subsequently experienced disease progression either on neoadjuvant immuno or chemotherapy were not included in the study, as it only incorporated the patients who underwent radical cystectomy following the therapies. And the data also does not provide regarding the performance status, treatment-related toxic side effects, the progression-free survival, recurrence-free survival, the PD-L1 status, or the tumor mutational burden, all of which would have contributed to this analysis if available. The study concluded that the neoadjuvant immunotherapy is an alternative to neoadjuvant chemotherapy for patients with muscle-invasive bladder cancer. They have a similar pathological downstaging. However, phase 3 trials have to be conducted to further evaluate the same. There were no bias or conflict of interest in the study. The study showcases the strengths of the study includes that it showcases non-inferiority of neoadjuvant immunotherapy to neoadjuvant chemotherapy in downstaging of the disease. The study also shows non-inferiority of neoadjuvant immunotherapy in terms of initial overall survival in patients up to 36 months. The study does not differentiate the type of immunotherapy, however, received by the patients in individual arms. The study does not mention if all patients received platinum-based neoadjuvant chemotherapy, and the study only focuses on patients undergoing radical cystectomy, excluding those patients who progressed their disease despite receiving the neoadjuvant treatment. Regarding the critical analysis of the study, whether the study addressed clearly the focused issue, yes, the study expressed clearly that neoadjuvant immunotherapy was equivalent in terms of neoadjuvant chemotherapy in its pathological outcome. Regarding the way that the study recruited the patients, the study incorporated well the 1:1:1 nearest neighbor propensity match. It incorporated well the age, sex, gender, comorbidity status, the location where they received this treatment, and the clinical T staging prior to initiation of therapy. Hence, the way they recruited was good. The exposure accurately measured to the minimal bias was not there because the study does not mention at all that the neoadjuvant chemotherapy that these patients received was cisplatin based or not, which is a major limitation factor in this arm. It also does not mention individual therapies of neoadjuvant immunotherapy drugs that this patient received, because each drug has different pathological downstaging and outcome measures as previously mentioned by us. Was the outcome accurately measured to minimize the bias? We can't say, because the authors measured outcome based on pathological downstaging of the disease only, which included radical cystectomy data, whereas the patients who had progressed were not included. So there is a bias in this study. Have the authors identified all the important confounding factors? Yes, they did incorporate the confounding factors and match them accurately. Have they taken account of the confounding factors based on the design and analysis? Yes, they have done so. Was the follow-up of the subjects complete enough? Yes, they have done a 5 years follow-up of the subjects. However, they have analyzed survival based on 36 months, not at 5 years. Was the follow-up of subjects long enough? Yes, as a traditional 5-year overall survival rate that they had done is mentioned. Now, regarding what are the results of the study shows that there is a non-inferiority of neoadjuvant immunotherapy as compared to neoadjuvant chemotherapy in the downstaging and overall survival of patients at 36 months duration post-surgery. And regarding how precise are the results of the surgery, the results are precise as compared with previous trials done regarding neoadjuvant immunotherapy drugs. We do believe in the result.
I think we can stop here and do more with the discussion. Huh?
Yes, sir.
Yeah, okay.
So, very nice presentation, Siddharth. Maybe we start with Dr. Nayak and Dr. Sanjay. They can start discussing with Parth, and I'll put it at the end. Dr. Nayak and Dr. Sanjay.
I think who is the person who will be discussing?
Dr.
Sir, I'm
Parth.
Dr. Parth Shah from Safdarjung Hospital. I am discussing about this.
Just at the outset, just tell me if this is a good study, this is a bad study, or average study. What will you rate? If you have to rate this study, what would you tell this study on your opinion?
Sir, coming to the positive aspect of this study, the previous 3 trials which has been done on the immunotherapy, they are the single arm trial and they didn't.
Listen, the given answer. If it is a good study, it is an average study, it is a poor study. What will you say?
Sir, I say it is an average study because it has a positive strength and lot of the negative aspects also regarding the study also.
What is, in your view, is the positive strength of this study, and what is the negative strength of this negative?
Sir, on my view, the first of the positive study, positive finding is the sample size is large. Another, they have eliminated the selection bias by using the nearest neighbor propensity caliper match. The third is the detail that they have mentioned is of clinical relevance. For example, the current standard of care for the treatment is the neoadjuvant chemotherapy, and as we know that because of the renal function and other condition of the patient, the more amount of the patient are cisplatin eligible. So if the finding of the study is positive, we can go for the immunotherapy for this patient. Another, they have evaluated both the aspects, the pathological and the survival. In the pathological aspect, both the complete response rate and the response rate, the patient goes to the non-invasive. For survival outcome, they have measured the overall survival rate for the patient at the 36 month. And the most strength.
What are the negative points of this study?
For negative points, it is the retrospective observational study. The randomization is not possible. Another is the data is taken from the National Cancer Data.
It's a retrospective study, so they have actually countered that by doing a propensity score matching. That's the
Coming to that only. They have do the propensity score to reduces the selection bias, but among all the parameters that they have excluded, the one parameter that they did not mention is the intention for the therapy. Whether the immunotherapy they have given to the patient, either this immunotherapy is given because the patient was cisplatin ineligible, or this immunotherapy is given only because they want to take the patient to the trial for the immunotherapy. So this could be a point of selection bias. Another is the data is taken from the National Cancer Database. In National Cancer Database, they have differentiate the treatment on the basis of the code. Either the patient has given the chemotherapy or the immunotherapy. They did not mention about the regimen, whether the treatment is given for the GC regimen or MVEC regimen, or in case of immunotherapy, whether they have given the pembrolizumab, betazolimumab. Another, the immunotherapy is given on a duration of 2014 to 2019. Even on the current guideline, this is the off-label treatment and not recommended in the guideline. So the basic protocol or the follow-up for the immunotherapy is not mentioned in the study. The majority of the immunotherapy that is received in the treatment are on the trial basis. So the better response rate can be due to the superior care received or the general health of the patient that is given to the patient. Another is though they have compared the Charlson comorbidity index between two groups, the renal function of the individual patients is not mentioned in this study. So we do not know about the cisplatin eligibility or ineligibility of this patient. Another is they have taken the N1 clinical N1 group also. Even in the current clinical scenario for the neoadjuvant chemotherapy, the N1 patients are not included. The chemotherapy that we are given to the N1 patient are considered as a systemic therapy. And in this study, after giving the systemic therapy, the patient who are not responding to the N1 therapy, what kind of treatment they have received is not mentioned. Another is the concept behind which study is the patient that who are not eligible or who cannot tolerate the side effect of the cisplatin, whether we can give the immunotherapy to this patient or not. But they did not do the head-to-head comparison between the side effects of the immunotherapy and chemotherapy. Another is the previous single arm studies like Pure 01 studies. They have taken the PD-1 status and the tumor mutational burden. These two and the primary result of the PD-1 factor in the conclusion they have given that this immunotherapy is the effect of immunotherapy is more in patient who are PD-1 expression is positive, but because this is a retrospective study and the no data of available regarding the PD-1 expressions.
Okay, I must say this is fantastic. Hang on. This is a fantastic actually analysis of the paper. So to summarize my point of view, I would say, though it is a large sample size, that's a very strong point, and they have done a propensity score matching. But actually, if you actually read this study, this is a very poorly done study because most of the important factors are not there. As you have already mentioned, you do not know whether these patients are actually receiving immunotherapy or saline or even. Nobody knows. Just because somebody has written immunotherapy, you do not know what actually they are receiving. At the same time, they have written chemotherapy, you do not know what they are actually receiving. It is carboplatin, cisplatin, whatever, nothing. So to compare at the end of the stage, it's okay. You actually found out at the end of the study, there is a difference in overall survival in those who are receiving immunotherapy and chemotherapy and those who are not receiving any neoadjuvant therapy. But then you do not know what actually they are receiving. So to give a blanket statement that neoadjuvant immunotherapy is as good as neoadjuvant chemotherapy without even knowing what they were receiving, that would be actually very generalization statement. And second thing, you have already mentioned that. Second thing, I already mentioned that they have only taken patients, those who were actually undergone cystectomy, without knowing how many patients are actually clinically T0, those who opted not to either undergo cystectomy or those who are actually progressed clinically. That part we do not know from this study. Suppose there are patients, those who became clinically T0, they did not want to undergo cystectomy, they want to be on bladder preservation protocol. So we have no idea about that set of patients and those who progress. So it is very biased. Actually, they're only tried, though their aim was only to see the pathological downstaging. From that point of view, that's okay. The study is okay. But the indication of immunotherapy, again, was not known. You do not know what are the indication for immunotherapy and what immunotherapy were given. That was also not known. So there are many negative points of this study. Just because actually it is published in European Urologic Oncology with an impact factor of 8.2, actually it doesn't merit actually this is actually not very good study. That's my point of view. Dr. Ravi, maybe you can give your opinion.
Yes, Sanjay, you want to opine? I think you've been silent for a while.
Yes. Yeah. Actually, I was listening because the discussion and the critical analysis part was nicely covered. As Dr. Naik said, that there are lots of flaws in the study, but still, I believe that this kind of retrospective study can give us a very good insight about doing further good prospective study, and they can be a future guide for proceeding good future level, good level of evidence with some good prospective study. So even with all those flaws, we should, at least we should read this kind of studies, and we should believe, because initially doing this kind of a prospective study without a retrospective background is difficult. Though they have not mentioned the status of TURBT, because there are many patients who probably had a very good radical TURBT and there was a post TURBT, there was nothing, pathologically no tissue left. So those stratification was not mentioned. So this is, I think, also has impact on neoadjuvant therapy, because if in a group of those who received chemotherapy has a huge number of patients with a clinically N0 after TURBT. So probably the result may be biased with that. And the duration of therapy, I'm not very sure. I couldn't find out in the in the paper that whether the duration of chemotherapy was standardized. That cannot be, because of so many hospital and everything are involved. And even the lymph node status, whether they have mentioned pathological lymph node status after the post radical cystectomy, that I'm not very sure. And post-operative complication, surgical complication, that should also be part of the study, because the kind of immunosuppression with immunotherapy and chemotherapy is different. So that should be also part of the study.
I think great. With such great comments, I think we should write to European Uro-Oncology and they'll retract the paper. You know, we have actually dissected it so much that I get a feeling that it's the worst study we have done. So I think these are inherent biases of involved in any data set. If you see 7,30,000, may say they could only have 7 lakh, they eliminated 3,000 patients. So automatically the data, a lot of data is missed out in such retrospective. But as you rightly said, Sanjay, that this gives us insight for futuristic studies which would have all this biases taken care. And the message for the residents is, don't take it just like because in European oncology and a published that we start giving immunotherapy to all our patients. No, all we understand is, yes, there is some option after the chemotherapy ineligible patients, and then there is more evidence to be generated based on this article. I think that's where we will stand. Thank you very much, Dr. Samir, and I congratulate Siddharth and Parth for an extensive in-depth analysis. Actually, they made our job so easy that I don't have to say anything out of it. Thank you.
Thank you, sir.
Thank you, everyone. And that was an excellent discussion, and compliments to both the presenter as well as the discussion, Dr. Parth, and all the experts. And I'm sure a lot of things to be learned from there. I wish we had more time, but we'll have to move on.
Very good job.
Thank you, sir.
Yeah, excellent. Yeah,
yeah, wonderful.
Thank you so much.
Thank you.
Thank you. So we'll move on, and I'm sorry to Dr. Chandramohan for keeping him waiting. There was slight change in the schedule and then we got delayed a bit, but we have an expert for the next session, which is the surgical crafts video session. And Dr. Chandramohan does not need any introduction really. And we are fortunate to have him demonstrate to all of us the fine and tips and tricks and nuances of doing an RIRS. So this is a video session and I invite the experts, Dr. Ishwar Dayal from RML Lucknow, Dr. Umesh Sharma from RML Delhi, and Dr. Tanuj Pal Bhatia. So experts can please take over, and Dr. Chandramohan sir, you can start sharing your screen and start the video.
Yes. I thank once again North Zone Urology Society, particularly Samir and Rishi Nair for giving me this opportunity. Dear experts, with your permission, I will go ahead with the RIRS, how it should be done with around 15 years of experience. Do you have my slides?
Yes,
visible?
we do. Yes.
Yeah.
Visible.
Yeah.
Go ahead.
So this RIRS surgical technical aspect, as you all know, it is a good choice of treatment for up to 1.5 centimeter. But ideally, multiple small stones, post-PCL residual stones, post-TSWL stones, it is better. So directly going to the surgical aspect, because the talk given is on that basis, we have to look at the flexible scope, laser, access sheath, and accessories. Not going into the detail. Flexible scope is approximately 70 centimeters length. It's very important, out of which 50 centimeters length is flexible. Other part is rigid, which is in your hand. This is the basic mechanism of how the transmission in a fiber optic bundle, around 2,000 to 3,000 fiber optic bundles in the flame of glass fibers will be there. Once they break, it will not be visible very nicely. It shows as a dot. But the things have changed. Now it is a digital scope, no conflicts of interest. Any company, the chip on the tip will be there like in our cell phone camera. So that captures at the tip of the scope. That's why they are little thicker, little less flexible. And that will be transmitted directly to the screen with a copper wire, like an electrical wire. So the durability is better, and there is no interruption like in fiber optic scope. So future is rapidly changing to the digital scopes. Access sheath, whether you use suction or not, this has one obturator and one outer sheath through which the flexible scope goes once this is parked in the ureter. Usually, not to go into the details, Encircle, Encompass, Dakota baskets are three. This basket has become famous because when you hold the stone, usually in RIRS, shifting of the stone is not done. As only in lower calicial stones, it is done. When you are shifting, if it is really heavy, this basket will relieve that. Whereas in the encircle basket, it may trap it and then you will be into trouble. That is the only thing. Now coming to the adapters, everybody know to control the water flow, these adapters are necessary. Laser mission, lot of people ask which is good. Both are good for stone disease, holmium and thulium. We are not discussing about this thing. In my case, where video I am showing 8 minutes, I have done with RIRS with holmium half time with thulium. You cannot recognize when I have shifted from the holmium to thulium. That is the answer. Now, laser fiber, no doubt, 200 micron fiber only to be used, not even 275. Unless you keep at one place all the three, you don't know exactly which is bigger. 150 micron fiber in thulium fiber laser has slight advantage about water flow. Flexible scope parts is only theory. That's the control body will be there, insertion tube will be there, light guide will be there, deflection controls will be there. Only one pediatric scope is available, which is of a lesser length from the coral starch, but the diameter is same. So no scope is separate. The digital view is good. This is the digital view again. What is the smallest size scope everybody is asking? 7.2 French from HugeMed is presently available in India. 6.2 is coming from Poussin and HugeMed in the next few months to India, already launched in Dubai. They make a difference. Suction has come a way in the RIRS where if you suck through the access sheath, this is the way the suction can be done. If you suck through the scope, this is called scope intra-suction. So you can suck only the fine powder with the flexible scope. Now, coming to the surgery. Access sheath insertion should be done under CM over the guide wire. There is no doubt about it. If you are used to it, it is not difficult job. If it is giving resistance, don't pass it. Put the stent and come out. That is the first point. There is another way when high bladder neck, where there is a suspensor ligament is tight, median lobe is there. You can insert over the ureteroscope, pass two guide wires. With ureteroscope threaded by the access sheath, you can go inside and thread it. It is snugly fitting. The needle scope from the wolf snugly fits with 25 centimeter access sheath of Cook. This is very handy technique. Without CM in pregnancy, you can do that. Whenever you are doing RIRS, like one of the case study discussion, SIRS, water outflow is very, very essential. Naturally, 600 to 700 ml of water will go into the kidney. It has to come out through the bladder or through the access sheath, without which kidney will get into trouble. Quickly, laser settings. If you are painting, you use 10 Hz and 0.5 joules or 1 joule. That's all. If you are using chipping, again same. That means 10 Hz 1 joule, 10 Hz 1 joule, 10 Hz 1 joule. If you remember, 90% of the settings are over. After that, you adjust your speed. Popcorn is the only thing you have to look a little bit. That in holmium, you don't have choice other than 15 Hz. Whereas thulium fiber laser, you can go up to 100, 150. Even though Meson says 2000, which is incorrect, frequency up to 100 Hz. More the frequency, more the wobbling, more the stone touches the laser fiber, more faster it becomes powder. But this more leads to raised temperature. So better to use less frequency is recommended by many of the studies. If you want to fragment, you have to use high energy, that is up to 1.5 to 2 joules, and frequency low is a bladder stone. You want to use as a pneumatic lithotripter, not like powdering. In bladder stone, why you want to make powder? You make exactly pieces 4 and take them out. So coming to the technique, method of holding is don't hold tightly. A lot of the juniors learn very fast RIRS. Only 2 weeks of observation is sufficient. Hold with fingers and have your thumb at the flexion, whether it is digital scope or the scope. Don't bend like this. Don't insert the laser fiber in a flexed position. That is the commonest cause of damage. That's very important. Always you should switch off the lights and see whether the laser fiber is intact. You need not test with the laser fiber tester. It is cumbersome. You can use at least this technique. Now coming to the video of 8 minutes, my time allocated is 12 minutes. I will finish in that. Now coming to the video, this is a live video. I will explain while it is going on. Whenever you wanted to do RIRS, this is the ideal case. Male patient se zyada female patient is better. First thing is ureteroscopy with 6 by 7.5 ureteroscope, whatever company. That is the normal caliber of the ureter. See how I am negotiating properly the ureteroscope balancedly into the sacroiliac joint part of the ureter and then into the horizontal part of the ureter, that is the at the level of the spinal processes. Now this stone is seen. I will like to push it. No question of doing URSL with laser because respiratory movements it may touch. Now once you feel that the ureter is good, you pass a thick guide wire 0.032. Now I am passing access sheath. Whether it is with suction or without suction, it doesn't make difference. Pass under the C-arm. Pass without pressure. Slowly you thread, it easily goes. Any experienced person in URSL can understand that it easily goes. This is the sheath which is going into the kidney. If it goes easily, it is not harmful. There is a suction mechanism here. You can understand because this is the latest I included in this. This is the suction attachment to the access sheath. By the side of the access sheath, there is a side connector, Y connector. Everybody of us know this is the suction to collect the powder. This is ultimately connected to the normal OT suction with 100 pressure. These are the movement of the scope. It is too short period to explain everything. Now, once the flexible scope goes inside the kidney, first thing you have to wait for 5 minutes till the water comes out. Don't start the case immediately. Once the water starts coming out, the vision will be very good. See, sometimes this pelvis collapses, sometimes this pelvis distends. You should have visual idea. This is the sheath which is just, see the air bubbles are sucked out. See the air bubbles are sucked out. This is the advantage with suction. Good vision is there with all the digital scopes. You go inside, stabilize the scope, start doing dusting only. When the stone is large, this is I am using holmium laser with 6.4 only. See, the painting is the technique, dust is the outcome. Paint don't stay in one place. The moment you break the stone, beauty of RIRS is gone. So you paint over the stone slowly, make the dust. While painting, you make nice powder. If you want, you can come by the side and chip it. This is chipping. By the side, you chip it. By the surface, you paint it. Why you wanted to paint on the surface? The stone surface area don't decrease. Otherwise, it will move. If the stone volume is decreased without affecting the stone surface area, that means one paper of the book you remove so that paper will not move. It is in the pelvis. Slowly we are doing low tidal volume up to 250 ml and frequency of respiration approximately 10 to 12 is the best. If you are doing under spinal anesthesia, you have to be little more patient. That's a little tedious job. It's up to you, but it is cost effective. Now, I am doing with the holmium laser. A lot of people ask, holmium, is it good for stone? Very good. No need to go for thulium fiber laser. Both are 30 watts enough. Here I am using 50 ml syringe, slowly flushing by a senior technician. If you are using gravity, very good. A great vision is not important. Low pressure is important. Now I am changing to thulium fiber laser. Same 1 joule, 10 Hz. You will not see any difference in the pulverization of the stone. See, it is same, exactly the same. So there is no point. Only some people say that enucleation can be done with thulium fiber laser of low wattage. That's why sometimes we use. That is not the subject today. Now, till the last minute, I am not breaking the stone. If you break the stone, the two pieces will go into different areas. They will be moving and you cannot do surgery properly. Movements of the flexible scopes are very much limited. They should be done only at the level of the wrist, not at the level of the elbow, not at the level of the shoulder. Now, as much as possible, I made powder. When the stone becomes very, very, very thin, you cannot do anything. What can you do? It will break. That time, if you push the stone into the calyx, it cannot escape. Ultimate idea is that every drop of the stone should be powdered. So at this level, see, I have pushed the stone into the calyx. That is the secret to have a better SFR. Now you make the stone into pieces. They cannot escape because your scope is blocking the calyx. This is all cell phone recorded on the cell phone is digital, scope is digital. That's why vision is good. You need not edit this video. Like this, I am coming out and taking out the small powder because there is a Y junction. See, all the powder is coming out. Now I randomly fire. You cannot do painting at this level, but this should be done at the last part of the surgery. As much as possible, do it powder. Last part when fragments are there, use popcorn. For that also, you don't require 100 Hz. Very large stones, it's okay. See how they are coming by the side of the scope, by the side of the scope. Some stones cannot come by the side of the scope. They will come directly through the access sheath. So this is a fan suction. You don't have this, you completely powder and come out. Naturally, the powder will come out. But spontaneous satisfaction, visual clearance of the entire kidney will be there with this type of the fan sheath. Only disadvantage is at the moment it is 10 French. Crossing the PUJ is concern. Yes, it should be a concern for the junior. It should not be used casually. The smallest access sheet that is available with the companies is 9.5 French, which is good. 35 centimeters will land up in the mid ureter. All the digital scopes goes in that. So there is no need to worry. There is no need to use fan suction. First 30-40 cases, you do like this. At the end, for academic purpose, I am showing how the contrast intravasation and extravasation should not happen. The calyces should be collapsed. Then on that day, chances of sepsis, chances of complications will be less. Even though that is not a 100% criteria, intact PCS system is good thing to see at the end. No harm. Now, when you are coming out, see, I am sucking out all the contrast. See, deep inferior calyx, how the flexible scope is going. This is only for demonstration. There is no scope. Now, while coming out, slowly inspect the ureter. See, I am coming out. There is nothing wrong in inspecting the mucosal capillaries. If they are seen, no injury at all, then stenting is better. If already you have stented, you have done so much powder, you need not put the stent. See how ureter is dilated. So with this, the surgical aspect of the this thing I have covered. I don't want to show any more cases. To conclude, RIRS is well accepted procedure now. Ureter accessibility, accommodability, distensibility. Accessibility means up to upper ureter, rigid scope should go. Accommodability means it should be able to accommodate 6 by 7.5 scope. Distensibility means when water is going, it should distend. Post-radiotherapy ureter, even if 6.75 goes inside, water will not come out. Dust is the aim at the end, whoever may be the surgeon. As of now, better procedure this is for less than 1.5 centimeter stone. Thank you once again, Narjun, for giving me this opportunity. I hope I have limited my talk in the stipulated time. Thank you.
Thank you, Chandramohan sir, for a very nice talk which covered every aspect of RIRS in today's date. I have a few questions for you.
Sir.
Yeah, Tanuj,
yes, sir.
just a minute. I'm sorry, I forgot to mention earlier that we have a resident here as a part of this panel, and he is Dr. Ashish Ranjan from SGPGI Lucknow. So you can also include him in your discussion. Yeah, please go ahead.
Yes, sir. Dr. Ashish Ranjan. Are you there, Dr. Ashish?
Yeah, good afternoon, sir.
Good afternoon. Have you prepared any slides to add to the talk, or?
No, you can ask your questions.
Just few questions,
Ashish
sir.
can come in.
Okay. So I think we should give chance to the resident first to ask a few questions.
Yeah, okay, all right. Okay.
So, Dr. Ashish, you have any questions for Dr. Chandramohan? Any doubts you want to clear?
Sir, yes, sir. Few questions like when to decide in what case to pre-stent and then go for the definitive procedure afterwards, sir.
Important. The 6 by 7.5 generally considered as the normal size of the ureter. If it is going easily up to the upper ureter, not at the lower ureter, that day you can safely insert. Then if you have already given anesthesia, so it's a waste of anesthesia. We cannot do anything. That is a primary negative factor of the RIRS. We have to accept.
Okay, sir. Second, sir, second question regarding this, sir, what is the preoperative antibiotic usually you use at your institute, sir?
I am using ceftriaxone sulbactam. Previously, I used to use amikacin. Dr. Mayank Agarwal, very particular about antibiotic coverage, said that stop and see. 7 years back, I stopped the amikacin. No much difference. I am using single antibiotic in the form of ceftriaxone sulbactam for 3 dosages, morning, night, and next day morning.
Okay. Sir, any role of keeping a stent prior to keeping the stents, safety guide wire, sir, along with the ureteral SSC?
For first 50 cases.
For the beginners, sir.
For the beginners, correct. First 50 cases, always put the stent and do the case. Even after stenting, if you put a small guide wire outside, it will make a lot of difference in water drainage. No harm. For traditional teaching, always safety guide wire, no harm.
Okay. So role of this role of this RGP or contrast.
Yeah, if the CT scan, which usually we do, if it is a solitary stone, there is no point using radiation for the theater. If it is multiple stones, 8 stones, you are missing something. Either in the beginning or at the end, you do RGP, go to all calyces so that stone is not missed. But solitary stone, if it is in the pelvis, why you wanted to do RGP? Not necessary, unless bifid system is suspected.
Okay, sir. Sir, any role of staged RIS? Do you consider any time like what you have anticipated as stone burden?
That is also, you have prepared very well the questions. The 1 hour usually in good hand is a long hour. For example, if I am doing more than 1 hour means unnecessarily I am stretching for a large volume. Either you might have gone for PCNL or stop and do the staging. Always better, because edema happens in the ureter, in the kidney, and we don't see that. That is a problem.
Sir, last question, sir. Like the size of stone, like we are dusting, you told to dust the stone. We have dusted it. How to get the visual impression that now the dust is dusted enough that the stone fragment will come out, sir?
Yeah.
Theoretically, it is to like 250 micrometer.
Yes, yes. See, it is very subjective criteria. People say laser fiber, tip of the scope, all these things. But your experience in the calyceal lumen, if you are seeing 100 stones, they cannot be 2 mm, 5 mm. So compare with the calyx total surface area with your scope going closer to the stone. If you go close, stones look big. Even then it is falling in the screen area. It is definitely less than 1 mm. Then you can safely leave it. The problem is large volume stones. You can miss the big stone 1, then SFR becomes 0. That's why don't make the fragments. If you are making fragments, relook RIRS is recommended for large volume. Volume is more important, which is more than 1000 to 1500 cubic mm. If it is there, you should be careful in RIRS.
Okay, sir, how you follow up your cases, sir?
Usually. Only ultrasound, because every time you cannot do CT, every time you cannot do X-ray IVP. good ultrasound after stent removal 2 weeks is fair enough that whether you have done good job or not. 2 to 3 mm stones, if they are there, let them fall off. Convince the patient at 3 months of ultrasound is a fair evidence that what you have done. If it is showing more than 8 mm stone, that means SFR is not good.
Good
Thank you so much.
questions, Ashish. Yeah, good questions asked by you. I think you have covered most of the things. I have just a few questions, sir. One
Sir.
is, do you think, is there any relevance and role of talking about fiber optic scopes today? How relevant do you think they are in today's practice, and how they are going to be relevant in future?
Sir, fiber optic scopes have served for 2 decades, so we should not say that they should be kept apart. Even now, a large volume, for example, daily if you are doing 6 RIRS, the fiber optic stokes will last long, especially if you are using a single person in the unit. Single person, large volume center, fiber optic will give better result.
Second thing is, sir, which one do you think is the better way of using the suction, through the scope or through the sheath?
Sir, naturally, sir, sheath is bigger, so up to 2 mm you can suck, whereas scope is smaller, 3.6 French. That means only less than 1 mm. How much powder you have to do to make less than 1 mm? And second thing, why you wanted to suck less than 1 mm? Lot of seniors are saying that less than 1 mm, no need. So ultimately, suction through the access sheath has some meaning. Suction through the scope, such a small 3.6 French, has less value.
Right. Last question, which is relevant to one of the journal presentations. Have you ever used antibiotic in irrigation? Do you think there is a role in your practice and in our routine practice?
Technically, a lot of people used betadine, gentamicin, but the bacteria, once pressure rises, goes into the body. Before that, whether your gentamicin will kill it or not, it is very difficult. Technically, it is not correct to depend on all these bypasses. You have to realize that if the pass matrix outflow is not there, stop the procedure and do PCNL. PCNL has less intrarenal pressure. RIRS has more pressure. Do not depend on irrigation fluid antibiotic at all.
Agreed, sir. Agreed. Thank you so much. Any other questions,
Dr. Ishwar, Dr. Umesh?
Yeah,
Sir.
Dr. Umesh here. Am I
Sir,
audible?
yes, sir.
Yes.
It's always pleasure, sir, Dr. Chanmon, sir, to see you doing RIRS, and definitely you are a master of this procedure. So I have just few questions that in your current era, do you do any dilatation of ureter prior to putting the uretic sheath? What we do during rigid
sir. No, sir. I will not do dilatation. In only one condition, if the patient is willing to go to outside country within 1 week, if the stone is small, I will do dilatation first 5 minutes with 4 by 6.5 scope, next 5 minutes 6 by 7.5 scope, next 5 minutes 8 by 9.5 scope. This is the only method of dilatation because visually you can go to the upper ureter, you will not injure anything, and you yourself or attendant, the surgeon will stand with scope for 5 minutes so that technically it dilates. In that case, you use new access sheath 9.5. Usually it goes, but still I am telling the water outflow logistics will be poor. This is only applicable for less than 1 centimeter stone who does not have insurance in USA or anything and want to get it done. A borderline consideration, but unethical.
Okay. So better to stage the procedure if your
No
access
doubt.
sheet.
No doubt. Primary negative point of RIRS is staging.
Okay. And the second question about this fans technique, this fans suction sheath, which is routinely now being used by many urologists. So what is your, with the experience, what is, because this has some inherent disadvantage while you put it across the PUJ obstacle, across the PUJ basically. So do you find that it has some maybe PUJ inflammation, irritation later on in follow-up?
The best answer I can give is that entire surgery, you keep the access sheath below the PUJ and do the powder. Last 5 minutes, you put the access sheath in the kidney, just suck it out. Don't do any movements, front and back, flexion and extension. That way, it will avoid all the injury. But whatever said and done, UPJ is the most dangerous area. Visual inspection with your scope, the distensibility and accommodability is the key factor. Without, if snugly fitting access sheath, definitely cause injury and it may cause avulsion also. So better not to directly go with the fan suction sheath. After 18 years, maybe 10,000 cases we might have done. Now we are using with caution only, not in all cases. Primary RIRS, I am still not using fan sheath because it is bigger. But in future, 9 French can come, then we can use it better. But otherwise, large scopes, large sheaths in the small ureters, not good. That's why strictures are increasing. Everybody is saying we have to accept that.
So thank you. I think there is paucity of time. If there is any other.
Yeah, thank you, Ms. Dr. Ishwar. Do you want to
Yeah,
ask any questions?
good afternoon, Dr. Chandra.
Hello, sir. Hello, sir.
I have just one question. Actually, right now I am driving, so I just one question. There are inaccessible stones in calyx while doing while lasing, your laser fiber is not reaching up to the stone. In that any inaccessible part of the calyx, stone is lost and you are trying hard to reach there and your maneuvers have failed. How do you manage that?
Sir, there are 2-3 things which I do. First thing is you just flush at the area of the stone that it will come out of that calyx. That is the easiest way you pray the God. Second thing is, if the laser fiber is at 9 o'clock and stone is struck at 3 o'clock part of the calyx, nowadays scopes are coming, so many are coming with laser fiber coming at the opposite side. Then it may touch the stone. Last, I will tell you very important trick which I do is, put in the center of the calyx nearer to the stone, high frequency, 100 and 0.1. It creates vibration. Wait for 1 minute, it will come out. But this is applicable only for less than 1 centimeter stone. Not for large stone will not anyway come out. But majority of times in horseshoe kidney, I try in isthmus, they will come and touch with the laser fiber. After that, they become small pieces and they will come back to pelvis. Then you handle them better. This is the proper experience trick if I wanted to give to you. Frequency raise, keep in the center, vibration create, stone will vibrate and come out.
Thank you. Thank you, Dr. Chandra.
Sometimes what happens is a small fragment just becomes adherent with a calyceal mucosa and it's a big stone and you cannot leave it behind and your laser fiber.
The performance, sir. Very good question. That is very bad thing. Immediately you should think of PCNL. If it is more than 1 centimeter, PCNL is better. Don't try hard more than 5 minutes. It will not get up. It will not get up. You said is very important. The stone stucks and your water should not be pumped too much to get it out. It's a difficult situation.
Okay. So thank you, Dr. Chandra.
Thank you, sir.
For joining us.
Thank you, Samir. Thank you, sir. Nair, sir, for the opportunity.
Thank you,
I
Dr.
felt happy listening the journal club because next month onwards I am taking over as South Zone Secretary. I will see this and then follow, and it is like very useful for me. That's why I stayed 2 hours to see all this journal club. Very well conducted, sir. Thank you very much.
Thank you so much.
Residents would have definitely learned seeing you operate RERS. This session was basically meant only to for the residents to imbibe those tricks, how to start the procedure basically. And you very rightly emphasized the entry into the ureter and the exit strategies. They are the most important part of the surgery. So with this, we'll move on to our last session of the day, which is actually making the slides, how the soft skill session, basically how to make your presentation impactful and effective. And Dr. Ankur Mittal, who better than Dr. Ankur Mittal to present on this topic? Dr. Ankur. And the chairpersons for this session are Dr. Gautam, Dr. Atul Khandelwal, and Dr. Anup Kumar. You can take from here, please.
Good afternoon, sir. I think at the outset, I would like to thank NZUSI for this opportunity. Are my slides visible? Are my slides visible, sir?
Yes.
Okay. So I think after a long day of a lot of knowledge and lot of aptitude, today the last session probably is about soft skills. So I think making it soft, we'll be discussing much on how to make an impactful and effective presentation. So why we are bothered about giving a good talk? It's a critical skill in today's profession, and it improves the ability to persuade, and really it is a game changer and it is the first impression which matters. The complete procedure presentation in the couple of minutes will go through this outline. We'll have a base station in Dehradun and definitely we'll reach somewhere target over Kedar track to attain our target. So we need to define presentation objectives. They should be clear, well defined. The key message should be determined, and we need to know what do we aim. Seeking to inform or inspire our audience, introduce a new procedure, sharing a data, teaching, rallying support. If all these goals are there, we have a desired outcome. We have heard all our speakers throughout the day. We have heard Chandra Mohan. If we see the presentation, how he did it, he was there to tell us something about a technique. That type of presentation is different when you teach something. So I think every presentation is different. So the benefit of these objectives are to stay focused, on track. It guides you for development of your narrative, helps in selection of visual aids, improve overall structure and flow of your delivery, and definitely increases the likelihood of achieving the desired outcome. We need to understand our target audience. We need to assess their knowledge and interest. If we are addressing our students, we should know what we need to give them. If we are addressing a population of a senior urologist, we should know what we need to convey. So we need to deeply understand their need and preferences. We need to anticipate questions and objections and definitely align with our expectations. With this keeping in mind, whenever we need to make a presentation, we need to craft a compelling narrative. So identify our story, note down the turning points, mark our resolutions, incorporate personal stories and real-world examples as we have seen in the earlier presentation, and definitely carefully structure the content. So the first thing which comes here is slide template. So a lot of template we see, but the template we need to select should be clean, minimalist, and aesthetic. Include only one idea per slide. And the key message should be the center stage for our slides. And definitely we should make use of the white space. If we talk about fonts and spacing, we have sans serif and serif. I think always good to use sans serif, understable fonts. They are more clear, more clarity. If we talk about font size, not less than 24, title 34, 36. Vardhana definitely is good. 7 to 8 bullets, 7 to 8 words. We all understand. And do not use all caps except slides. These are some basic things which can, come in our presentation. Let us see when we talk about color palette and contrast. So see, here is an example. Whenever we keep a slide, it is always good to have a light background and have a dark text. Example, maybe black on white or blue on white. This is most preferred type of a color contrast used in slides and vice versa. So here is a, the logo of a Domino's, right? When we use using this logo, when we are making a slide, if we use the same colors in the slide, it really looks appealing and more understandable as done in this slide. No more than 4 colors need to be in a slide. Otherwise, it will be more distracting to the audience. Let us see this example. This is, we have a logo of UAA, Urological Association of Asia. We see the color combination in that logo. And the same color combination is used in the slide everywhere to make it more clear. So this is one of the ways to use your color contrast and all. Using images, multimedia, and graphs. I think it's good to use funny and relevant HD images, GIFs, or videos, but they should be limited to 1 or 2 per slide. We should not overburden the slide with all these things. Graphs need to be used rather than text, much more understandable, more clear, and we need to avoid some over complex chart in our presentation. One example in today's was our journal clubs. If we take our journal club is one of the most difficult thing to grasp in a short span of time if you don't have that article in hand. And I think the speakers and the presenters have done a wonderful job to make it simple. Probably there's a good way of presenting a journal club. So animations, if we talk about, yes, it is good to have animation and transitions, but be consistent with it. Don't change animation every time. A lot animation can cause problem. And there is one important, very good thing is morph transition. I think now it is available. Morph transition is always good to use it because it makes your sliding continuous and more explainable manner. And definitely more you use, it can also distract your audience. Some additional points I want to emphasize. You should cite your sources, give credit wherever is due, use in-text citations, use references, And yes, please avoid plagiarism. So this is an example of morph transition. You will see that how the image is being used in the respective slides. You will see it. Check the spelling and grammar. We need to have a final look and realignment. Important point is you make a presentation, but before you use it and save in a pen drive and you need to use somewhere in a different laptop or system, please embed those fonts in a PDF. Sometimes you make it in your system and you go and present somewhere else and the complete fonts changes, the setting changes. And always save those presentation in your Google Drive. It will help you. See, whatever good presentation we make, the most important is you need to do a practice and rehearsal prior to your presentation. Identify the key moments of your talk. Stop there, take a pause, put some stress on important points. Don't be monotonous. Practice them loud. Simulate the real thing among friends and have a good feedback from them before your real presentation. Time management is a crucial thing. Time allotted to us is important. We need to stick with. Make your presentation in the same timeline. Don't exceed it. Make it simple. Prioritize the task. Eliminate distractions and schedule some micro breaks in your presentation in between. And yes, whatever you do when you are on stage or you are in virtual platform, have a feel of presentation. Cultivate a commanding stage performance. You have a body language. See your audience. Face them. Move here and there on the stage and express your facial expressions as if you are talking it to them. So, and you should never show your back to your audience on your presentation. Delivery technique, I think, is also a crucial part. As I said, we need not to be a monotonous type of presentation should be there. Your vocal variety should be variable. You should have a variable tone, pitch, and volume. Somewhere go slow, somewhere go fast, somewhere, you need to pick up. So that is important, clear, loud, avoid pacing, and just don't read your presentation. It is not mandatory to read whatever is written in your presentation. It may be written, speak what is relevant to that slide, stick to your time. Most important, once you have done your presentation, how you will improve. So, just making an effective presentation is also important to have a good feedback. Anticipate and prepare for your questions. Actively listen and engage with your listeners and beneficiaries. Respond in a calm and attentive manner. No harm in embracing the feedback, to accept that feedback, whether it is positive or negative. Be constructive and please respond with a clarity and confidence. So once your feedback is done, it is always good to reflect, analyze, and iterate. So you need to thoughtfully review your feedback, identify the areas of improvement, and work over those. Definitely your further presentations will improve as you go ahead. And I need to conclude my presentation now by saying that a lot of apps are coming up now. You have artificial intelligence in place, you have ChatGPT, you have different apps, Prezi and all. So all those are basically aiding you in making a good presentation. But I think our reasons, and we should not forget that whatever these apps can do, but they can never replace your thought process. So your possibly understanding the text and the topic and making a good framework is a crucial thing for making a great presentation. You can use these apps definitely to improvise your version of presentation, but that cannot replace you making a presentation. I think, thank you all. In the interest of time, I just made it, just a quick review on the soft skill presentation. Thank you, everyone.
Thank you, Dr. Ankur. Any questions, Dr. Anoop? Your comments on this, please.
Dr. Ankur, as usual, can you hear me? Am I
Yes,
audible? So
yes, sir.
very excellent presentation as always by Dr. Ankur Mittal, and he's highlighted all the important points. I think he's covered most of the points, how to make a good and effective presentation. And I think there's some discussion also from the president.
Yes,
he can also come in.
From BHU, there was one.
Yes, Dr. Sulabh is there from BHU. We can.
Yes.
I think he can ask few questions and then we can give the final.
Yes. Sulabh, are you there? Sulabh?
Okay, so I think
yeah, we move on. Yes.
We move on. So Dr. Ankur, I think I just want to highlight few things. Most important thing is time. I think that is the most important thing. We should consolidate the time allotted, and I've seen many speakers overshooting the time, even in the rest of the conferences. So this is one thing. Second is speak slowly and should be very clear voice, loud and clear and soft. And you are, as you rightly said, should be interactive with the crowd. That is very important. People should know that you are interacting, not a monotonous. And use of pictorial things, like you emphasize graphs, videos, and animations. I think these are few things to make your content more effective. And don't use many of transitions. Like I've seen many presentations where like people use so many transitions coming from here, there, that distract the audience. Make it simple and not too many colors in the slides, as you rightly said. And most important thing is you should know your content. What content you have to, and what is your audience. Suppose I'm teaching MBBS students, then my content should be at the level of MBBS. And if I'm teaching MCS students, my content should be there. And suppose I'm taking like Chandra Mohan, his presentation was excellent. He was targeting the postgraduates. Suppose this presentation was for the urologist, for senior urologist, or like for post MCS urologist, then his presentation will be some different than this presentation. This is, I think we should know how should we target our audience. Thank you.
Yes, sir. Thank you so much.
Sir, I would like to sir,
Yes, Sulabh has joined in. Okay, yes.
Sir, what's the role of animation? Like, it is too much to have too much animation, or does it make it more interesting, the presentation?
See, Shalabh, I think the most important thing is it's not bad to have animations. Animation can be there, but always you should limit your animation to 1 or 2 per slide maximum. You can use your GIFs or smileys or some animations, but limit them. And those animations should have a concordance with your text actually. You should not go out of the way that you are putting some animation that has no relationship with your text. Those animations should have an answer to the question which is explained in the, so it should replace your some content in the text. That's why there's the importance of animation putting in that particular slide.
Sir, one more question I would like to have. So, especially in general clubs and presentation, can we have conclusion first and then we move on to like the material, method, and discussion? Because many a times, many audience lose their interest while coming up to the conclusion part. So, once we start with the conclusion, that might be more interesting to the audience. They will be more engaged towards the presentation.
Sorry, I am not getting your question. You want to say in general club we should start with conclusion?
What he's saying is, you have the conclusion first in order to keep the audience engaged.
That is a good feedback.
Yeah.
Let me tell you, see, whenever we are reading a paper, there is always an abstract first. So your point is the abstract should be presented in a very concise manner to the start, and that is a very fair point. We may look at considering that. Thank you.
In fact, Dr. Rishi, if I may come in my opening remarks, I wanted to say that only that first one should present the abstract, because that way you get to know what are you going to find in the entire study, so that you can focus better on certain critical steps. In fact, that's a trend even in our department whenever we do JCs. So it's a clear message that abstract should be presented first, so that everyone knows what are we dealing with what are we expecting in the paper.
Right.
We'll definitely include
it. Atul, anything? Gautam?
Excellent presentation, Dr. Ankur. If as you discussed, first is rehearse. Thank you.
Yeah, is Dr. Gautam around? No. Can I say a comment about this presentation?
Can I ask a question? Can I ask a question if you have time?
Yes.
Yeah, just Rahul, let me make a comment and then you can come in. I mean, since we are already overshot, so another minute won't make a difference. What I wanted to say was, make the beginning of your presentation interesting. If you can bring some humor into it, bring a humor. So engage your audience right from the very beginnings. If you start in a boring, dull way, then people lose interest very fast. So you can make an impactful beginning in the first, make your audience engaged with you, and then you can continue with that. And second thing for the residents is don't try to read whatever is written on the slide. Just keep it very short bullets and try to use your own language. Expand on what are the clues which are written on the slides, rather than reading full sentences and writing full sentences. So those are the two comments that I want to make.
So one thing I want to add on to what Samir is saying for the residents' sake is, see, initially it is difficult actually when you present such topics that you need to gather that, understand that subject. I think once you do rehearsals and understand the subject, it becomes easy to read your slides. If you don't rehearse and understand your subject, then you will be stuck with that. You need to read each and every word of your slide, and you will make more busy slides. Second point is, even if you're having some more content in the slides, you can rehearse and put some, boldly some letters on those slides, and that will help you in your presentation to read only those bold letters instead of reading the full sentences. That also can help the initial beginners. Dr. Rahul, please.
Yes, Dr. Rahul.
I just wanted to ask one thing, Ankur, very nice presentation, especially for all the beginners. You have recommended that use of the wireless speaker and the mouse and move on the stage. For how do you justify that for medical presentations? That's my question.
See, I think it is feasible. It is feasible. See, not mouse speaker. You can have recently we had a conference of female urology in Hyderabad, and I think there was a system that it was not under control of. There was just a single, and the person can move throughout the stage just a button away and can use the whole stage for presentation. So it is feasible. Probably it depends upon the audiovisual guy if he can provide us that facility in the stage. And it matters, sir.
Yeah, I think for oration kind of thing, it is something which looks good. But in a scientific presentation, it's okay if you're on a dais and presenting, because there are many things which you want to navigate while you present. But in a oration, yes, no questions are being asked, so anybody can do anything. He can actually come half panned also and do it, because he's an invited, a respected person. So, but for a standard presentation, let's keep it that a podium kind of thing makes a better sense, I would say.
So I think, all right, it's time. I invite Dr. Rishi to give the concluding comments and close this.
Oh, thank you, Dr. Samir, for conducting today's session and guiding it all through, and especially all the faculty who prepared for the residents and were so enthusiastic in their participation, and especially the residents as well who actually participated this so meaningfully in the entire program. So I would invite all the residents to give me feedback on this, even if they have not given feedback here. You can always write to me on the official email, or even WhatsApp me anytime on whatever topic or issue that you may feel you want the NZUSI to work upon. We are open to all kind of suggestions and even critiques as well. So with this, we come to the conclusion. Dr. P.P. Singh I don't think he's there at the moment. So we'll conclude today. Thank you everyone for joining us today. And we have a physical meeting coming up of North Zone in July, that is 20th and 21st of July. That is the midterm meeting on BPH. The entire surgical issues revolving around the BPH scenarios would be discussed over 1.5 days. And I urge all of you to please join us there physically at Patel Hospital, Jalandhar on 20th and 21st of July. So thank you so much. Good afternoon to everybody. Once again, bye.
Thank you. Thank you. Bye.